In my view, we're going to be talking about an issue that has not gotten the attention that it deserves from the medical community, from the media, and certainly from members of Congress, and that is the crisis of long COVID. And long COVID, as we all know, is the fact that after people get COVID, sometimes there are symptoms which simply do not disappear. And we're going to hear from our panelists in a moment about that. So what I would like to say to our panelists, and by the way, we have a full house here, we have an overflow room over there, and I suspect a lot of folks are watching this on TV and on live stream. And I think there is the sense that something is going on in America which is serious that we're not addressing. So I just want to say to our panelists and all those who are dealing with long COVID, we hear what you're experiencing. We take it seriously. We think we have not, as a Congress, done anywhere near enough, and we hope to turn that around. The reality, as we're going to hear from our panelists in a moment, is that long COVID is a very serious illness that can have devastating consequences for those who contract it. In America today, and the estimate is that some 16 million people throughout our country have long COVID. It affects people of all ages and all backgrounds, although we're going to hear a little bit of evidence that it disproportionately impacts people of color and lower income people. For far too many people who were previously healthy, and we're going to hear from a former athlete this morning, who are leading active and productive lives, they have suddenly found themselves bedridden and grappling with strange, debilitating systems that they could not conceive of having gotten as a result of long COVID. And the truth of the matter is, and we'll hear from our experts after we hear from the patients, that we still don't know why, we don't know the cause of the disease, but this is what we do know. We know that long COVID can include more than 200 symptoms, including serious cognitive impairment and severe cardiovascular and neurological problems that can continue for weeks, months, or even years after initial infection. We know that people with long COVID have experienced a wide variety of chronic symptoms, including extreme fatigue, insomnia, migraines, brain fog, dizziness, shortness of breath, loss of smell or taste, and sometimes those diseases can be so debilitating that it leads literally to suicide. It's the case in my own state where a young man, previously healthy, committed suicide as a result of all this. So let us be clear. The symptoms of long COVID are not minor inconveniences. They are debilitating conditions that affect the ability of people to work, to care for their families, and to live full lives. And here is what far too many do not know. Long COVID, and we're going to hear more about this morning, can affect anybody who has had COVID-19, from those who experienced mild symptoms to those who are severely ill. Further, although you may not have long COVID after your first infection, each reinfection can increase the risk of developing it. In other words, if you're under the impression that once you've gotten COVID, you don't need to worry about it ever again, you are mistaken. This is an escalating danger, particularly for those who have suffered repeated infections. It poses a severe threat to public health, and it demands our immediate and focused attention. Now, let's be clear. The impact of long COVID is not just a health issue, it is an economic one as well. It is estimated that as many as 4 million Americans are out of work due to long COVID. The annual cost of those lost wages alone is around $170 billion a year. So what should we do about it? First, we must educate medical professionals on how to adequately diagnose long COVID, better understand the risks associated with it, and identify potential therapeutic options. Far too many patients, and I think we're going to hear a lot about this morning, with long COVID have struggled to get their symptoms taken seriously. And far too many medical professionals have either dismissed or misdiagnosed their serious health problems. This crisis is made even worse by the fact that long COVID patients often require multiple specialists to treat their complex symptoms. The existing shortage of healthcare providers, from primary care to mental health providers, means that far too many Americans are unable to access affordable, high-quality care when they need it. That's another issue that some of us hope we can address in the near future. So let me just conclude by thanking our panelists, both the patients and the experts who we will be hearing from in a moment. And let me give the mic over to Senator Cassidy.
Thank you, Chair Sanders. I'm a doctor, and I worked for a long time with people who had chronic fatigue syndrome.
I think I speak for the whole committee in thanking all three of you for being here and for educating us and the American people about what you and, in your case, your child has experienced. Let me begin my questioning with Ms. Vasquez. And I know you have experience, obviously, not only with yourself, but you have interacted with many, many hundreds of people with long COVID. Is one of the frustrations that the medical community or others do not believe, in fact, what you are experiencing? Is that one of the problems that you're going through?
Yes, absolutely. I daily, it seems like, hear from patients who have been experiencing long COVID symptoms, symptoms that are clearly as a result of their infection with COVID, being dismissed by doctors as anxiety, as pandemic stress. It's, I think, quite alarming that even with the media attention that it has gotten and all of the grassroots advocacy that we've done to educate, providers and the community about long COVID, it is not enough. There really needs to be, I think, a stronger, louder government campaign around long COVID for public health, and as well as clinical education to providers, particularly primary care. I mean, you said yourself that primary care is overwhelmed. It's really, really difficult to assess a patient in 15 minutes and get them everything they need.
Let me jump to Ms. Beal and Ms. Helm, just to pick up where Ms. Vasquez left off. How has your, what kind of impact, what kind of effect have you had in terms of reaching out to the medical community? Have you found doctors understanding of the problem? Have you been able to get the help you need, Ms. Beal, for your symptoms? Are others in a similar place?
Thank you so much for your question, Senator. Early on in my long COVID journey, it was difficult to find a doctor that knew what long COVID was. And I even had a doctor tell me that she didn't believe that long COVID was real. So, and that's hard when you know you're sick and you know it's real, and you have a medical professional telling you that they don't believe it. It's hard to get anything out of a conversation like that. I've become more selective in which physicians I see. I ask every single one of them, have you heard of long COVID? Are you treating any other patients with long COVID? And I think in the last year, more of the providers are more aware of long COVID, so that's been very helpful.
Good. Okay, Ms. Helm, you've introduced us to something I think that's even less attention than the overall crisis of long COVID, and that is how it impacts young people. I guess you have, not by choice, become somewhat of an expert on COVID and young people. Can you tell us a little bit about what you have learned as to how many kids are experiencing long COVID, whether they're getting the kind of treatment that they need, how it impacts, a teenager's life? Speak into the mic there, please.
Just being on social media and connecting with all these different groups of parents, a lot of times you get to talk directly with other parents and hear their stories. And there's a lot of parents that are struggling to get treatment for their children. I mean, they're trying all kinds of different, medications, supplements, even hyperbaric chambers. I mean, they're doing anything to try and help their children feel better. And I think the biggest thing in relation to the question about the doctors I come across, the doctors I've been around are not dismissive. They just say, I don't know. I hear that a lot from doctors. I don't know, I don't know, I don't know. So what I do is, because I've got the information from the clinic and the study and stuff, I tell them what I know. I was at the gastroenterologist yesterday and I said, did you know COVID lives in your gut for months after infection? And she said, no, I didn't know that. And I said, well, tell everybody at your office. And then she looked at me and she said, yeah, well, she looked at me and she said, well, how do I do that test? I don't even know how to order that test to see if they have COVID in their stool. And so I think that's part of the problem is the doctors need the information so that they can help the patients, because they just don't know that COVID is doing this to people, I don't think. They're shocked usually when I tell them the stuff that I've learned.
All right, I'm running out of time. My last question is, what good question did I not ask any of you? All right, then, Ms. Mack,
Yes. I think a question that I would have liked to have answered is why it's important to include patients in research and education for clinicians and providers. And I think we have been living this. We have been living with long COVID since the pandemic began. And patients have been living with, infection-associated chronic diseases for generations. We know this stuff backwards and forwards, not only because we live it, but so many of us have had to do our own research. I am heavily invested in PubMed and Google Scholar. I can read a paper. I send papers to my providers. We are experts from a lived experience, and because some of us are getting in there and doing the research ourselves. So that's why it's important to include us.
see that I knew I would ask a brilliant question, and it was you, Senator Cassidy.
I defer to Senator Dr. Roger Marshall.
Well, thank you, Chairman and Ranking Member, again. And this is personal for me. One of my loved ones is one of those 16 million people that suffered from long COVID, incapacitated for some 2.
Senator Cassidy, you're now recognized for an opening statement.
Thank you, Chair Sanders. Let's just be clear. Everybody on this panel cares about the high cost of prescription drugs and wants to work on real solutions to address this. But it's also clear that this hearing is not about finding legislative solutions. It's kind of following a formula. We publicly attack private, well, I don't, but others, publicly attack private citizens for being successful under capitalism. We grossly oversimplify a problem and blame corporations. We demand CEOs come before the committee for public verbal stoning. We reject the offer to send top executives with subject matter expertise and responsibility regarding the issues at hand and threaten a subpoena when CEOs are suspicious that they won't get a fair shake. Hold the hearing, get sound bites, then pick another set of CEOs for a show trial, but we don't pass meaningful legislation. If that sounds familiar, that's been the hearing with Starbucks founder Howard Schultz, Moderna CEO Stefan Bancel, and now this hearing with the same formula. I would have gladly joined the chair in exploring solutions to address the high cost of prescription drugs. I'm a doc. I worked in a public hospital for the uninsured for 25 years. I did my best to get care to those who otherwise would not have received. I am aware of this. I'm also aware of the perverse incentives. The kind of like, my gosh, it shouldn't be high, but it is high. Bad actors game the system, and we need solutions that benefit patients and improve access. But the majority was not interested in working with this side of the dais to hold a serious hearing to inform serious legislation. They didn't seek Republican input. The goal was to haul you guys in, to cry capitalism and blame these corporations for the high cost of drug prices. Now, by the way, of course drug companies play a role, and hopefully we'll get answers today to legitimate questions about how drugs are priced. But the problem is far greater and more complex than individual companies, or even a set of companies within an ecosystem which is incredibly complex. Why do Americans pay more for certain drugs than patients in other countries? To understand, we need to have a serious effort to navigate the network of perverse incentives throughout the healthcare system. I lived in it for 25 years. I am very kind of aware of it. Taking a substantive look at insurance benefit design, price transparency, regulatory barriers, intellectual property barriers, the perverse effect government discount programs have upon prices charged to commercial patients, etc. One example, just to say again a little bit of complexity here, the 340B drug program resulted in a $54 billion in drug discounts in 2022. But we actually don't know if those discounts lowered prices for the patient who bought the drug. There are reports that patients paid cash when the intermediary took the full price, even though 340B should have lowered it. That is a serious investigation being conducted by this side of the dais that the other side of the dais was not interested in participating in. That is an understanding of an ecosystem. I understand there's no one more eloquent than Chair Sanders on Medicare for All. And we can cherry pick examples of how other countries are doing something better. I could cherry pick the opposite. Canada is struggling, just to show you that there's a complexity here, let me just take an example. Canada is struggling with specialty care. In May of last year, the Canadian government began to send 4,800 Canadians from British Columbia to Washington State to, quote, ensure people have faster access to life-saving radiation treatment, end quote. They can afford their system because we're right next door. Relatedly to this hearing and to that, Alison Decluseau, a Canadian woman, paid for her own treatment in the United States after the Provincial Health Authority in British Columbia denied her access to life-saving chemotherapy. Canada had a lower cost drug so low they didn't carry the chemotherapy. So she paid for it out of pocket in the United States so she could have life-saving chemotherapy. The United States is not perfect, but if we cherry pick from other countries, we have to do a more thorough investigation to see is there a balance there. Now let's return to prescriptions. Canadians pay less than we do. Let's figure out why. But let's also point out that public health insurance in Canada only covers 21% of newly developed drugs. Now, maybe that's a trade-off, but I can tell you, you tell an American that they can't have access to a life-saving drug, they're going to see you in court. They're going to sue, and they're going to say, I want that access. The UK only covers 48% of newly available drugs. Americans just would not tolerate that. It's fair to say that Ms. Decluseau, or those radiation treatment patients, or those not getting the newly developed life-saving drugs as quickly, might die in those countries that don't have access to the same treatments as do we in the US. These are serious questions. One more time, I'm a doc. I am aware of this. But we need to fully consider all these issues and then maybe bring you in at the end. But we'll bring in with a context which is complete as opposed to isolated. As I said at the start, it would be best if this were a genuine exercise. I am so willing to do the work on this, as are my colleagues. We've shown that willingness on work on PBM reforms and generic drugs. And even though the chair and I got off to a rocky start, we did some pretty good work on that, Mr. Chair. I think we've got some good bipartisan legislation. So this committee, I agree with you, can accomplish that. But I don't want the committee to devolve into a CEO whack-a-mole that ends up with no serious legislation as a result. Further proof of what I consider the unserious and cynical nature of this hearing is that the minority asked the chair to have a witness on the panel that could actually explore some of these issues side by side these CEOs. That was turned down. We wanted an academic expert in drug pricing who could provide unbiased and substantive input to the issues at hand. Our witness was not allowed. He'll be on the next, but the way this works is this gets all the publicity and the next one gets crickets. And so we've not had that opportunity. And I'll also point out we didn't split the majority and minority witnesses into different panels during several hearings which promoted kind of labor union issues. I can think of no reason to not allow our witness to be here now, except perhaps ruining the optics. As I said at our last markup, what ends up being hollow messaging gives DC a bad reputation. Folks want real answers. They want relief from high prices. It is in part what we're going to hear today, but it will be separated from a context that would have made it a lot more productive. If you're telling voters you're going to do something when you know at the get-go you'll have no legislative solution which emerges, and that's why folks don't trust. So if we're just looking for a social media clip, then I suppose we've accomplished something. But let's make a difference for the people whom we represent, for those patients in hospitals where I once treated who otherwise would not have access to care. We have the ability to craft meaningful legislation. Let's do it. With that, I yield.
Chairman, thanks for being here today. It's pretty well known where our chairman stands on this. His worldwide view, pretty clear that he believes you guys are setting drug prices, and it's all about corporate greed. I'm a true believer of capitalism, and I believe that we have the best healthcare system in the world. Problem is, we've got the federal government involved in it, and it's not implemented the way probably it should be. That being said, I just got a few questions here on a couple of things. Mr. Davis, can you explain me something? The Biden administration has two huge priorities. Dictate prices of prescription drugs, specifically small molecule drugs, and cure cancer. Can you walk me through how those priorities might be in direct contradiction of each other?
Well, Senator, and I think what you're referring to is what is called the pill penalty.
That's correct.
Underneath the IRA, and what that does is effectively says that at 9 years post your first approval, your price or your drug will be negotiated, and if it's a small molecule, it's 13, if it's a large. The issue that raises is that it disfavors small molecule development, and the reality of it is, if you look across the majority of cancer treatments, they are still small molecules. And as Chris pointed out earlier, the development of cancer drugs usually starts in a phase starting at the very most sickest patient, the last stage of disease, and then you work forward into earlier stages of disease where, in fact, you can start to maybe talk about cure. To do those studies in early stage disease, often called adjuvant or neoadjuvant care, and we have 9 approvals in that space, those studies can take 7 to 9 years to do. So obviously, if at 9 years, I have to significantly reduce the price of that drug to a point that it is potentially, at basically no profit, my incentive to do those follow-on studies is not there. And that is our worry, that if you look at cancer care, you're going to see patients suffer because we can't get to really talking about cure, which is in earlier stages of disease. I'd also point out, you didn't ask about Alzheimer's and neuroscience diseases, but most CNS diseases also require small molecules because large molecules, biologics, can't penetrate the blood-brain barrier. So we are disincentivizing some of the largest areas of sickness and chronic need in our society through that pill penalty you referred to.
Thank you. Mr. Boehner, we hear a lot about how healthcare costs are ridiculous high. I think all of us would agree to that to some degree. I want to peel back the onion here a little bit. Today we're being led to believe that these costs are due to corporate greed. I want to know if we're going to talk about some additional drivers of healthcare costs. When the federal government dumped trillions into various industries during COVID, we upended our markets and drove prices through the roof. When I talk to healthcare folks back in Alabama, labor cost is one huge problem. But there are other costs, including supplies and raw materials. What impact are these having on the drug development and high drug cost?
Certainly, Senator, when we look at the cost basis for us doing what we do as a company, which is to bring forward new medicines for patients, we have to factor in all of those costs. I'll give you an example. In cellular therapy, which is really transforming very late-line hematologic diseases, these are very complex medicines. You're taking patient cells, manufacturing them, and re-engineering them to really target and hone in on cancer cells, and then you re-inject them in the patients. This is really a first-generation technology. Unfortunately, it has very high labor costs because this is one that's very manual. It's a multi-step process to manufacture these products. Their transportation costs, their raw material costs, all of those factors go into a cost of these first-generation medicines. Now, we're very focused on trying to innovate to get to a second and third generation quickly so we can bring those costs down, not only because it's important for us to be able to funnel additional research into development, but also so that we can bring ultimately the cost down to patients. So they are absolutely a factor, Senator.
Thank you. Mr. Otto, I'm going to ask you this with your accent in mind. We'll probably have a tough time. But I know you're probably aware in 2021, you weren't the CEO, I don't think, at that time, but the Biden administration announced a mandate that U.S. troops and personnel must take the COVID vaccine in order to serve in the military. Are you familiar with that?
I'm familiar, sir. Thank you.
Are you aware that more than 8,400 troops were kicked out of the military for declining to take the COVID vaccine? These were mostly young, healthy Americans for whom COVID risk was low. Are you aware of that?
No, I was not aware of that, sir.
Thank you. Did you or did anyone at Johnson & Johnson encourage the Biden administration to mandate this COVID vaccine to the military? Are you familiar with that?
We did not, sir.
Okay. How much did Johnson & Johnson benefit financially from the administration's military COVID vaccine mandate? Could you have any kind of guess to that?
Our effort in the COVID vaccine that we collaborated with the government, it was a time of a global emergency, so we thought that as a healthcare company that cares for patients, we needed to collaborate with the U.S. government. That was entirely non-for-profit.
Do you think the soldiers who were expelled from the military was the right thing to do, and should they be reinstated?
I was not aware of this situation, sir. I am not aware of these circumstances, so I cannot comment on that.
Thank you. Thank you, Mr. Chairman.
I'm not an apologist for Big Pharma. In fact, when corporations manipulate government to their advantage, crony capitalism, I'm an unfettered critic. But in defense of capitalism, I am a consistent, unapologetic advocate. Milton Friedman once wrote that if you want to create a shortage of tomatoes, just pass a law that retailers can't sell tomatoes for more than 2 cents. Instantly, you'll have a tomato shortage. I might also add that that's true of prescription drugs. Virtually every shortage of drugs that we've seen in the last few years involves price controls that drive out production of the drug. One reason the United States leads in pharmaceutical innovation is because while the U.S. adhered to a more market-based pricing and rewarded innovators, Europe adopted stringent price controls in the 1980s and 90s. It's not surprising that we lead the world in innovation and Europe does not. But unfortunately, this committee and this hearing is not here to celebrate American success. Instead, the majority drags us to conduct a show trial to harangue companies challenging the Inflation Reduction Act's price controls in court. They've simply brought forward people who question their partisan legislation. 10 years ago, the 5-year survival rate for patients diagnosed with advanced lung cancer was 5%. Terrible. Since Merck introduced the cancer drug Keytruda in 2014, the survival rate has grown nearly fourfold, 5% to 20%. We should be celebrating that instead of castigating people and telling them how to run their business and why are you buying your stock back? I have a friend with a genetic predisposition to cancer. He's alive today because of Keytruda. We should be celebrating that. Johnson & Johnson's Remicade was the first monoclonal antibody approved for treating chronic conditions like Crohn's disease and rheumatoid arthritis. Since its approval, Remicade has revolutionized treatments for inflammatory disease, made remission a reality for patients with debilitating conditions, and paved the way for development of other autoimmune treatments. When I began in medicine, virtually all patients with rheumatoid arthritis you could see from a distance had crippling, disfiguring arthritis in their hands. Now today it's rarely seen because of the advances of American companies under an American system that allowed profit to occur. In 1987, Merck pledged to donate the entire stock of its drug ivermectin to those suffering from river blindness. Nearly 37 years later, ivermectin donation program treats 300 million people annually with over 11 billion treatments shipped to endemic countries. This is charity, my friends, from capitalism. You don't get this under socialism because there is no profit under socialism. They have no money to give. They make extraordinary profits. Do they keep some up for their investors? Yeah, that's what they're supposed to do. But they also have some left over for charity, and you don't get that under socialism. Because of Merck's donations, 7 countries eradicated the transmission of the #1 cause of blindness in the world. Pharmaceutical innovation has improved cancer rates, cured hepatitis C, doubled the life span of patients living with cystic fibrosis. It goes on and on. We've tried price controls in general here. We did it in the 1970s under a Republican president, under Nixon. It was a disaster, and it led to lines at the gas pump. It was an ultimate disaster. A study at the University of Chicago found that 254 fewer drug approvals over the course of 18 years would happen under price controls. Under communism, they knew this. Socialism, communism, under the economic system of socialism. From price controls, it became a running joke. In Poland, during the Soviet era, there was a story of the guy went to the store. He was looking for eggs, and he asked the clerk, "Is this the store with no eggs?" And they said, "No, this is the store with no toilet paper. The store with no eggs is across the street." That's the story of socialism. That's the story of price controls. Scarcity and empty shelves are the inevitable result of price controls. Those who understand and appreciate capitalism do not need a show trial to dupe them into forgetting that price controls have never worked and never will. Let's get back to profitability. I don't think you guys did a very good job on answering this. Did you add into your estimate of whether it's profitable in Canada, whether or not it costs you $2.6 billion on average to develop it? You're talking about manufacturing costs. You're talking about how much it costs to make Keytruda and how much you sell it for, say you have a profit in Canada. Do you think it would still be a profit, Mr. Davis, if you added in all the R&D, the $2.6 billion to get it through this system, the apparatus of your company, and you divided all of that out for profitability? Would it still be profitable in most of these other countries?
I have not done that analysis, but I would say that the profitability would be marginal at best.
Do you think you'd have as much R&D if the whole world were Canada? Do you think you'd be developing dozens of new drugs every year if the whole world were Canada?
No, I do not.
So this is what we're arguing against. You know, sure, you can make it for pennies now, but it didn't start that way. And then people are like, oh my, it costs so much in the beginning. That's capitalism. That's the way it works in capitalism. Joseph Schumpeter talked about this, and he said, this is an old anecdote, but he said, the miracle of capitalism is not that queens have silk stockings, but that factory girls ultimately do. But in the beginning, only the queen has silk stockings. Rich people get stuff in the beginning. Rich people drive the innovation. The first calculators that came out, $300 for adding, subtracting, and dividing machine. Now they're like pennies or free. But you have to allow the price to be higher in the beginning, and the market brings it down as you have more widespread market. That's capitalism. We don't know what the correct price is. There is no moral price. There is no moral amount of profit. There is no business of any of y'all telling them how much stock to buy back. Their job is to make a profit. It's actually against the law for them not to maximize their profit. For you to sit in judgment of how much profit they should make and how they should run their companies, you know nothing of running companies. You know, nobody up here, maybe some, but almost nobody up here has run big companies, billion-dollar companies. And you presume somehow to say you're going to tell these people how to run their company. List price versus net price. List price means absolutely nothing. I charged $1,800 for cataract surgery. The government paid me $600. 2/3 of it, nobody stole that. It disappeared because it never existed. So if I billed $1 million in charges, I really was only billing $300,000 because that's what I was getting paid. But because of the confusing nature of the system, the list price is much different than the net. But to quote list price and then compare it to net price in other countries is completely and profoundly unfair. The list price means absolutely nothing. All of these fallacies need to be addressed before we begin haranguing American CEOs. Thank you.
Thank you for your questioning, Senator.
Thank you. So I just wanted to say at the outset that the last time I checked, when a buyer and seller negotiate for a price, that's capitalism. And I wanted to talk with all three of our distinguished witnesses today, because one of the things that strikes me that we are struggling with is I think at various times in each one of your statements, you talked about your price reflecting the value of your product. And the thing is, human health and life is priceless. So if that's the metric here, you will always have an excuse for charging increasing prices for these life-saving drugs. And what we are trying to do here is figure out how you can continue the innovation that Senator Paul just so eloquently spoke about. I would suspect that every member up here has a family member whose life has been saved by innovative medications or greatly improved. But at the end of the day, we have to find a way to allow you all to innovate, but also to make sure that the market here and the system here works for the very people whose lives you are helping to save. So I want to start with a question to you, Mr. Davis. While families in New Hampshire and across the country struggle to afford these life-saving medications, pharmaceutical companies are doing everything that they can to keep their prices and their profits sky high. And I know you've all talked about that not being the case, but let's just look at one thing here. One way that companies do this is by filing dozens, even hundreds, of frivolous patents that lock in their exclusive right to sell their drug for decades. By playing games like this with the patent system, companies block low-cost alternatives like generics from coming to market. Mr. Davis, the list price for Merck's cancer medication, Keytruda, is, as we've talked about, $190,000 per year. Can you tell us how many patents have been filed on this medication?
I don't have the exact number, but I would focus you on probably the most important patents, which are the composition of matter patents. In addition to that, we have formulation and manufacturing patents. There is one suite of composition of matter patents that we have, and those are what allow us to continue to have exclusivity.
Well, I don't think it would surprise you to learn that I do know how many patents you currently have. It's 168. This is what this looks like, sheet after sheet after sheet. Patent office records show that not only do you have 168, but half of them relate to the process Merck uses to manufacture the drug, not the way that the drug is used to treat patients. Merck is using patent gimmicks and loopholes to delay other companies from selling lower-cost versions of this medication, all while raising the price of Keytruda in the U.S. year after year. So it would be good if Merck would just stop blocking patient access to low-cost medications by using the patent system in this way. It's clear that Merck and other pharmaceutical companies, you are not alone, won't stop abusing the patent system to keep their prices high. So it's clear we also need to take action on that, and that's something we can do. Senator Braun and I have a bill called the Medication Affordability and Patent Integrity Act, which would help break up these patent walls. And I would urge my colleagues on both sides of the aisle to support that. Now, Mr. Duato, in your testimony, you mentioned that Johnson & Johnson provides financial assistance to uninsured patients in the United States. However, the barriers to access these programs are unreasonably high. For an expensive medication like your company's arthritis drug Stelara, what does a patient have to do to get assistance from the Johnson & Johnson program?
Thank you. We care deeply about patient access, and we put a lot of work in developing well and wide patient assistance programs. And we have mechanisms for patients to connect with us via mechanism like a website called Janssen Care Path, in which patients can access patient assistance. We supported 1.1 million people with patient copay assistance last year.
Well, let me just talk a little bit about that. The initial application, which I have here, is 6 pages long, and it requires pages of additional documents for income verification. In the fine print, this document even requires the patient to consent to a credit report check and other financial disclosures. Mr. Duato, everyone on this dais wants you to charge a fair price for your company's medications. But if someone does need assistance paying for their medication, this process has to be streamlined and easily available to anyone who qualifies. So I would urge you to look personally at this application. When somebody is dealing with a serious illness, the last thing they need to do is read the fine print and decide that they have to disclose a credit report, the relevance of which kind of escapes me. Mr. Berner and Mr. Duato, we could also increase competition by making it easier for generic drugs to get approved. Mr. Berner, let's turn to the BMS stroke prevention drug Eliquis. The list price, as we've talked about, is $7,100 per year. How many generics of this drug could a patient in the United States get at the pharmacy today?
Senator, in the U.S., there are not yet generics available.
Right. There are 0 generic versions of Eliquis available to patients, even though the original patents on the medication began to sunset in 2019, because your company has sued to block 2 approved generics from the U.S. market until 2028 at the earliest. Isn't that right?
Senator, we have allowed for generic entry in 2028. That's correct.
Right. So we have 2 generics ready to go. Your original patent is well past expired, but you still are actively trying to prevent generics from coming to market. Mr. Duato, the list price of Johnson & Johnson's autoimmune arthritis medication Stelara is nearly $80,000 annually. Similar to Eliquis, there are currently 0 low-cost biosimilar versions of Stelara available to U.S. patients. There are 0 biosimilars for Stelara available in the United States today because Johnson & Johnson has also sued to delay the launch of a low-cost biosimilar drug. So we need, you have all talked about the need to have speed of access, and Mr. Chair, I'm wrapping right up. Speed of access, getting drugs to market, but then you are actively working to block the less expensive biosimilars and generics to come to market, and that's something we should address. Thank you, Mr. Chair.
Senator Romney.
Thank you, Mr. Chairman.
Today is a busy day, as we all know. A very important vote's going to be taking place, and Republicans, Democrats will be meeting in their caucuses, so people are going to be coming in and out. I also think that this hearing is important enough that we extend the time for questioning from the usual 5 minutes to 7 minutes, if that's okay with folks. Let me begin by welcoming the CEOs of Bristol Myers Squibb, Chris Berner, we thank you for being here. CEO of Merck, Robert Davis, we thank you for being here. And the CEO of Johnson & Johnson, Joaquin Duato, for being with us this morning. Thanks very much. There is a lot of discussion in our nation about how divided our people are on many issues, and that is absolutely true. But on one of the most important issues facing our country, the American people, whether the Democrats, Republicans, Independents, Conservative, Progressive, could not be more united. And that is the need to substantially lower the outrageous price of prescription drugs in this country. According to a recent poll, 82% of Americans say the cost of prescription drugs is too high, and 73% say that the government is not doing enough to regulate drug prices. As a nation, we spend almost twice as much per capita on health care as do the people of any other country, $13,000 for every man, woman, and child. And one of the reasons that we spend so much is the high cost of prescription drugs in our country. The outrageous cost of prescription drugs in America means that 1 out of 4 of our people go to the doctor, get a prescription, and they cannot afford to fill that prescription. How many die as a result of that? How many suffer unnecessarily? Nobody knows. But my guess is it is in the millions. And I have talked to many of them in Vermont and around the country. Meanwhile, our insurance premiums are much higher than they should be, and hospital costs are soaring because of the high cost of prescription drugs. Further, the cost of prescription drugs in this country is putting an enormous burden on taxpayers and seniors by raising the cost of Medicare and Medicaid. Medicare alone spends at least $135 billion a year on prescription drugs. So this is not only a personal issue, it is an issue of the federal budget. Meanwhile, as we pay by far the highest prices in the world for prescription drugs, 10 of the top pharmaceutical companies in America made over $110 billion in profits in 2022. They are doing phenomenally well, while Americans cannot afford the cost of the medicine they need, and the CEOs in general receive exorbitant compensation packages. This morning, we're going to hear a lot from our CEO panelists about how high prices are not their fault and that the PBMs are forcing Americans to pay much higher prices than they should be paying. But let us be clear. In 2022, Johnson & Johnson made nearly $18 billion in profit, paid its CEO over $27 million in compensation, and spent over $17 billion on stock buybacks and dividends. That same year, Merck made $14.5 billion in profits, handed out over $7 billion in dividends to their stockholders, and paid its CEO over $52 million in compensation. And Bristol-Myers Squibb made $8 billion in profits last year, while recently spending over $12 billion on stock buybacks and dividends, and giving its CEO over $41 million in compensation. Now, why did a majority of members of this committee invite these three pharmaceutical CEOs to testify today? And the answer is pretty simple. Mr. Berner, we will want you to explain to the American people why Bristol-Myers Squibb charges patients in our country $7,100 a year for Eliquis, when that same exact product can be purchased for just $900 in Canada and $650 in France. Mr. Duato, we're going to ask you why Johnson & Johnson charges Americans with arthritis $79,000 for Stelara, when that same exact product can be purchased for just $20,000 in Canada and just $12,000 in France. Mr. Davis, please tell us later why Merck charges Americans with cancer $191,000 a year for Keytruda, when that same product can be purchased for $112,000 in Canada and $91,000 in France. And let's be clear, Johnson & Johnson, Merck, and Bristol-Myers Squibb are not just charging higher prices in the United States compared to other countries. They are also charging Americans much higher prices today than they did in the past, even accounting for inflation. From 2004 to 2008, the median price of innovative new drugs sold by these three companies was just $14,000, inflation accounted. From 2019 to 2023, where we are today, the median price of new drugs sold by these three companies was $238,000. In other words, Americans are forced to pay higher and higher prices for the drugs they need to survive. And let's be clear, the overwhelming beneficiary of these high drug prices is the pharmaceutical industry. How do we know that? Well, that is precisely what they tell their investors. According to their own shareholder reports, Bristol-Myers Squibb made $34 billion selling the blood thinner Eliquis in the United States, compared to just $22 billion in the rest of the world combined. Make their money in the United States. In other words, the U.S. accounts for nearly 2/3 of all global sales of Eliquis. Not a single dollar of this revenue is going to PBMs. 100% of it is going to Bristol-Myers Squibb. Johnson & Johnson has reported to its shareholders that it made over $30 billion in revenue selling the arthritis drug Stelara in the United States since 2016, more than twice as much as the rest of the world combined. Nothing to do with PBMs. Merck has reported to its shareholders that it made $43.4 billion selling the cancer drug Keytruda in the United States, compared to $30 billion in the rest of the world combined. Now, our CEO panelists from the drug companies will tell us this morning how much it costs to develop new drugs and how often the research that they undertake for new cures is not successful. And they are right. We appreciate that. But what they have not told us in their written testimony is that 14 major pharmaceutical companies, including Johnson & Johnson and Merck, spent $87 billion more on stock buybacks and dividends over a recent 10-year period than what they spent on research and development. More on stock buybacks and dividends than in research and development. In fact, Bristol-Myers Squibb spent $3.2 billion more on stock buybacks and dividends in 2022 than it spent on research and development. Johnson & Johnson spent $46 billion more on stock buybacks and dividends than it spent on research and development since 2012. In other words, these companies are spending more to enrich their own stockholders and CEOs than they are in finding new cures and new treatments. Now, the average American who hears all of this is asking a very simple question. How does all of this happen? What's going on? How could drug companies charge us, in some cases, 10 times more than they charge Canadians or people around the world for the same drug? How do they get away with this when so many of our people cannot afford the high price of the drugs that they need? How can it be, uniquely among industrialized countries, that these companies, not just these companies, but the pharmaceutical industry in general, can raise prices anytime they want, to any level they want? Want to raise double prices? Do it any way they want. How do they get away with all of that? And here, in my view, is the answer. The United States government does not regulate drug companies. With very few exceptions, the drug companies regulate the United States government. That is the sad state of affairs in a corrupt political system. Over the past 25 years, the pharmaceutical industry, not just these companies, the entire industry, spent over $8.5 billion on lobbying and more than $745 million on campaign contributions. And let me be fair here. Don't want to misspeak. They are bipartisan. They give to Republicans, they give to Democrats. And I am especially impressed by the Pfizer drug company. Pfizer is not here this morning, contributing $1 million to the Republican Party in Kentucky to expand its headquarters, named after Republican leader Mitch McConnell. But again, it's not just Republicans, it's Democrats as well. Unbelievable. This is an astounding fact. Last year, drug companies had over 1,800 well-paid lobbyists here in D.C. to make sure that Congress did their bidding. There are 535 members of Congress and 1,800 well-paid lobbyists, over 3 for every member of Congress. So if you want to know why you're paying the highest prices in the world, America, that's why. Now, here is some good news in the midst of all that. We are beginning to take on the greed of the pharmaceutical industry. As a result of the Inflation Reduction Act passed several years ago, Medicare, for the first time ever, is beginning to do what every major country on earth does and what the Veterans Administration has been doing for over 30 years, and that is to negotiate the lower prices of drugs, including Januvia, Stelara, and Eliquis. Let me conclude by saying this. I am proud of what this committee up to this point has accomplished. Last year, as you'll all remember, the CEO of Moderna committed during a Health Committee hearing that his company would make certain that no one in America would have to pay for their vaccine out of pocket. We appreciated that. In a separate Health Committee hearing last May, the CEO of Eli Lilly committed that his company would not raise prices on existing insulin products after having, in fact, lowered them. But let's be clear, much more needs to be done. I look forward to hearing from our CEO panelists this morning as to how they are going to go forward to substantially lower the cost of prescription drugs in this country.
Thank you for holding this really important hearing. Mr. Duato, looking at your arthritis drug, and we've talked already a little in this hearing about the difference in price between the United States and other countries. Annual cost around $80,000 in the United States, $20,000 in Canada, $12,000 in France. Are the prices that you receive from a country like Canada or France, which look to me to be about 1/4 of the price that you get from the United States, are those prices covering your costs?
Yes, they do. To clarify, Senator, the price in the U.S. is discounted by 70%, so the appropriate comparison would be $25,000 in the case of Stelara, if you are considering that price.
Are the prices you're receiving from these other countries, so let's say France, I'll give you the benefit of your argument. France is still 50% of the U.S. cost that you're claiming. Are those countries' prices covering your costs?
They do. The difference is that, for example, in Canada, which was the first country you quoted, Stelara, which is mainly indicated for inflammatory bowel disease, Crohn's disease, and ulcerative colitis, not for arthritis, is not yet reimbursed in the public system. So Canadian patients that want to access Stelara, they cannot do it in the public system because 8 years later, is not yet reimbursed there.
So you don't identify any free rider syndrome today in which the United States is paying higher prices, allowing other nations to receive lower prices?
I agree with you that the prices in the US are generally higher for medicines, more aligned than what you are describing, as the rest of the healthcare system prices are. The percentage of pharmaceutical expenses over total healthcare expenses in the US is 14%, and that is lower than most of the advanced economies. The real difference is that in the US, patients get access to therapy, life-saving therapy, years before they do in the countries that you mentioned.
If the United States were to restrict the prices we paid, would that create a different negotiating dynamic in countries that right now, for instance, are paying 50% of what the United States pays? Would it allow you in your negotiations to get higher prices from other nations that right now are paying far less than the United States?
We believe that price caps are not the way that innovation is going to be fostered. We have worked with the United States State Department and with US embassies around the world to try to reject the price caps that some countries, as the one you mentioned, impose. And we welcome the support of the US government in avoiding that these governments are ultimately imposing price caps on us that are not benefiting their patients neither.
What do you say to Americans who look at the way that you allocate revenue and wonder why, in your case, for instance, you are spending $6 billion on stock buybacks, $11 billion on dividends, and $14 billion on research and development? You spend all of your advertising time talking about the research and development spend, but I think most Americans would be pretty surprised, given how much the industry talks about research and development, that you are actually spending more money shelling out money to investors and buying back stock than you are on research and development. What do you say to folks who look at that and come to the conclusion that you care much more about keeping your investors happy and keeping your executives happy than you do in researching and development the next class of drugs that's going to help regulate?
We care deeply about patients, Senator, and we care deeply about being able to discover the next medicines that are going to address major problems like Alzheimer.
But explain to me how you justify that division of dividends and stock buybacks versus research and development. You could just choose, instead of using $6 billion to buy back stock, to put that into more research and development, but you don't.
Our level of R&D investment in the 2 years that refer to the $6 billion program buyback, which were 2022 and 2023, is 6 times higher. So in that period, we invested $30 billion in R&D and $6 billion in stock buyback. So we spent 6 times more in developing cures for patients than we did in stock buyback.
Well, I'm looking at 2022 profits and spending by Johnson & Johnson, and it shows me $11 billion in dividends, $6 billion in stock buybacks, $45 million in executive compensation, and $14 billion in research and development. Can you understand? Let me ask you a different question. Can you understand that one of my constituents in Connecticut would look at those numbers and think that you care more about padding the pockets of the folks that work for you and invest in you than in research and development?
Our priority is investing in R&D. We have spent $77 billion since 2016. And yes, we have to pay dividends because it's the only way that the company can remain operational and sustainable. Otherwise, if we are not operational and sustainable, we are not able to fulfill our mission of developing medicine for patients and making them affordable.
Mr. Bohr, you talked in your testimony about the United States has a healthcare system that prioritizes the important role of patient choice. I just want to present you with the case of one of my constituents and ask you about the choices that she faces. So I have a constituent who needs Eliquis. This is a blood thinner that is critical to her survival. She has priced a Medicare plan that gets her the best possible price. And that price is $350 a month. The average Social Security benefit in Connecticut is about $1,700 a month. And of course, somebody who's on Eliquis is likely on other drugs as well. So here's her choice. Her choice is to pay the $350 and go without food or pay her rent late, or not take the drug and risk heart attack or stroke. Is that the choice you're talking about when you refer to a healthcare system that prioritizes the important role of choice?
Senator, absolutely not. And in fact, I would say on behalf of all of our employees at Bristol-Myers Squibb, that is a choice no patient should have to make.
But she makes it. She makes it because you have chosen to price a drug at a point that is unaffordable.
Senator, we have priced Eliquis in the U.S. in our estimation. In fact, we try to do this for all of our medicines, consistent with the value it brings. And we're very happy with the fact that Eliquis is the leading anti-stroke drug.
Why not you put $8 billion into stock buybacks. Why not do $4 billion and instead take the rest of the money and bring the price of the drug down?
I'm going to keep people to 7. Senator Tuberville?
Thank you, Mr. Chairman.
Before I begin the first round of questions, let me remind our witnesses that while the Health Committee does not swear in witnesses as a general rule, federal law at 18 U.S. Code Section 1001 prohibits knowingly and willingly making any fraudulent statement to the Senate, regardless of whether a person is under oath. I would also say, in response to many of your testimonies, we are aware of the many important life-saving drugs that your companies have produced, and that's extraordinarily important. But I think, as all of you know, those drugs mean nothing to anybody who cannot afford it. And that's what we're dealing with today, that millions and millions of our people cannot afford the outrageously high cost of prescription drugs in this country. Now, my time and the time of all of the members is limited, so we're going to just, I'm going to ask.
Wait, are we starting the clock?
So my time is limited, so I'm going to start by asking all of you a number of questions, and I would appreciate it if you could respond with a yes or no answer. It turns out that in our dysfunctional and extraordinarily expensive healthcare system, hundreds of thousands of Americans have gone to GoFundMe in order to raise money to pay for their healthcare needs and for their prescription drugs. Let me ask Mr. Davis, if I might, have you ever searched on GoFundMe for your cancer drug, Keytruda?
No, I have not.
Okay. We have. I and my staff have. And we have found over 500 stories of people trying to raise funds to pay for their cancer treatments. One of those stories is a woman named Rebecca, a school lunch lady from Nebraska, with 2 kids who died of cancer after setting up a GoFundMe page because she could not afford to pay for Keytruda. Rebecca had raised $4,000 on her GoFundMe page, but said the cost of Keytruda and her cancer treatment was $25,000 for an infusion every 3 weeks. Mr. Davis, and please, yes or no, is it true that the list price of Keytruda is $191,000 a year in the United States?
That is close to being true, yes.
Thank you. Is it true that that same exact drug can be purchased in Canada for $112,000 a year and $44,000 a year in Japan.
Generally, yes.
Mr. Davis, even though the price of Keytruda is 1/4 of the price in Japan compared to the United States, does your company, does Merck make a profit selling Keytruda in Japan?
We do.
So what I understand is you make a profit selling Keytruda in Japan for 1/4 of the price that you sell it for in the United States. My question to you is a pretty simple one. Will you commit to lowering the price of Keytruda in the United States to the price of Japan?
Well, Senator, I think, first, I acknowledge the prices in the United States are higher than they are in many of the countries you said, and not for all drugs, but for many drugs, and that's the reality we face. But I think it's also important to point out that you get access in the United States faster and more than anywhere in the world. We have 39 indications for Keytruda across 17 tumor types in the United States. If you look across Europe, it's in the 20s. If you look across Japan, it's in that number or a little bit less. So there is a reason why the prices are different, and we need to be careful because we are also seeing in those markets that they are unwilling to support the innovation, and we are working hard to try to get them to understand the need to help fund the innovation.
I apologize for cutting you off.
That's fine.
There are two other, but I did want to make this point. Again, we all appreciate the breakthrough in important drugs that you and other companies have produced that save lives. No debate about that. But I do want to point out that after all is said and done, and after all the money we spend on prescription drugs and healthcare in general, the life expectancy in Japan is 9 years longer than it is in the United States. Senator Cassidy talked about Canada. The life expectancy in Canada is 6 years longer than in the United States. Life expectancy in Portugal is 6 years longer. Life expectancy in the UK is 4 years longer. Let me ask the last question to Mr. Davis. As I understand it, you made $52 million in total compensation in 2022. Will you commit to not accepting a single dollar more in compensation until there is not a single GoFundMe page for Keytruda?
Well, I can tell you at Merck, we are very much sensitive to what's happening with patients. That's why we have very important patient assistance programs. We commented on the fact that we have over 800,000 patients benefiting, where we provide free drug for those who can't afford it, as well as other assistance programs that help with copay and others. So we are very committed as a company to doing what we need to do to try to help alleviate the challenges patients face that you're focusing on, and that's my focus as the CEO.
Okay, thank you. Mr. Berna, with Bristol Myers Squibb. Carolyn from Florida says that she cannot afford Eliquis, and so she will, quote, stop taking it, though I need it to prevent the risk of having a stroke, end quote. Mr. Berna, again, yes or no, please. The list price of Eliquis is $7,100 a year in the United States. Dr. Melissa Barber, an expert at Yale University, has estimated that it costs just $18 to manufacture a year's supply of Eliquis. $7,100, what we pay, $1,800 to manufacture. Is it true that the same exact drug, Eliquis, can be purchased in Canada for $900 a year?
Senator, that's roughly correct.
Let me ask you this. Even at 13% of the cost in the United States, does Bristol Myers make a profit selling Eliquis for $900 a year in Canada?
Senator, we do make a profit.
All right, so you're selling the product for 13% of what in Canada, of what we pay in the United States, and obviously you sell it there because you make money. So, Mr. Berna, will you commit today that Bristol Myers Squibb will reduce the list price of Eliquis in the United States to the price that you charge in Canada where you make a profit?
Senator, we can't make that commitment primarily because the prices in these two countries have very different systems that prioritize very different things. In Canada, medicines are generally made less available, and it takes oftentimes considerably longer for those medicines to be available, on average, roughly.
I apologize. I do apologize. life expectancy in Canada is 6 years longer than it is in the United States. Mr. Berner, your company spent over $12 billion on stock buybacks in 2022. Given that reality, can you tell Carolyn why you can't lower the price of Eliquis?
First, Senator, let me say no patient should have to go through the types of choices that the patient you just described go through. It is our commitment to continue to bring down the price of medicines in the U.S., and I would love the opportunity to bring down the price of Eliquis in the U.S. Our net prices, what we are compensated, have actually over the last 5 years declined. At that same time, the list prices have increased. Why is that? Because of the complexity of this system and the billions of dollars in rebates that we have provided to intermediaries that unfortunately do not go to lowering the price of medicines like the patient you just described.
Again, I apologize. I want to get very briefly to Mr. Dueto, who's with Johnson & Johnson. Mr. Dueto, is it true that the list price of Stelara is $79,000 a year in the U.S.? Is that roughly right?
It's roughly right, but it's also true that the average discount of Stelara in the U.S. is 70%.
I
So
know
it's
all of that, and we've dealt with PBMs, and we're going to get to that, I'm sure, in this morning. Is it true that while charging $79,000 in the United States, that the exact same product is sold in Spain for $18,000?
I don't know the price in Spain. I can tell you that the average discount in the U.S. is 70%, so the price that you quote is 30% of that.
Okay. Mr. Dueto, is it true that it costs less than $15 a year to manufacture Stelara?
The manufacturing cost is only a component that goes into our pricing. When we price our medicines, we're looking at the value that the medicine brings to the healthcare system, our ability to continue to invest in research. We invested $15 billion last year. And also, we look at affordability. The average copay, if they use our copay assistance programs in the US for a patient using Stelara, is $10 to $15 per month.
I apologize. I'm over my time. I'm going to give Senator Cassidy the same time that I had. Marshall?
All right, thank you, Mr. Chairman. Mr. Bruner, I'll start with you. Bristol Myers makes this new miracle drug, Eliquis, relatively a miracle drug. You know, when I was in residency treating patients, I was using Coumadin, heparin, and then Coumadin. It might take 3 or 4 days to get someone heparinized, and then we switch them over to Coumadin. They might be in the hospital for 10 or 14 days. So in its own right, Eliquis, you know, saves money. It saves that length in the hospital and prevents hospitalizations as well. So I want to point that out. And as we talk about rationing care, we've discussed how we're rationing care in foreign countries. But I want you to speak about rationing care in this country. How do PBMs ration care when they take a drug like Eliquis and don't allow it on their formulary? Does that ever happen?
Senator, I'm glad you raised that point. We have had absolutely that case happen on multiple drugs. We've had it happen on Eliquis. We've had it happen where when we have not been able to reach an agreement with an intermediary on a rebate, that they've taken Eliquis off of formulary. And when that happens, those patients no longer have access to Eliquis, and they have to go on to another branded, or in many cases, they may go on to warfarin, as you say. Yeah. Eliquis is the #1 product in the oral anticoagulant space.
Okay. So I'm going to, sorry to catch you. So they have to go back to warfarin, the Coumadin, the drug that I was using in medical school in the 1980s, a drug with significant complications, a hassle factor. The patient has to go get blood testing done, you know, maybe twice a week as well. But with your drug, you know, one of the miracle parts of it is A, they don't bleed into their brains anymore, and 2, they don't have to go get their blood testing done once a week as well. So, you know, it's a huge amount of innovation. And it amazes me how much power these PBMs have obtained. Let's go to Mr. Davis next. I want to talk about delinking. And you have, at the time, a miracle drug of your own to treat diabetes with. There's a list price. How much of that, what percentage of that list price does typically Merck get at the end of the day?
So, Senator, if you look at Januvia, which is the drug you were speaking to, the list price is $6,900
Per year, for a year?
Per year. For Merck, we recognize $690 on that drug per year.
So of the list price, you're only getting 10%,
It's a 90% discount.
90% discount. Where does the rest of that money go?
Into the middlemen, into the system as a whole.
If we had the time and the energy and a chalkboard, would you be able to explain to me and show me all the little places that goes?
I could, but I think you appreciate it is highly complex, and so complex that at times even learned people who play in the space can't understand.
Well, certainly I can't explain it, and that's my point, is it's so non-transparent. We don't know where this money is going, but certainly we know that the pharmacy benefit managers are taking 50 to 75 cents of that dollar, and you're only getting 10% of it. I would like to know where the rest of it goes. Then I'll go back to Mr. Werner. Similarly, with your drug, with Eliquis, what percent of that list price do you think that you all are taking home?
Senator, it's a relatively smaller percentage. As I mentioned before, we've paid over the last 5 years about $100 billion in rebates and discounts, and the majority of that go to one product, and that's Eliquis.
Okay. Go back to Mr. Davis. Let's talk about, you all have an antiviral drug that's been approved. How many drugs did you go down when COVID hit? You were trying to develop multiple drugs. How many have made it across the finish line? What did you spend on R&D as you look at those all together?
Yeah, so when the COVID situation hit, we drove 2 or 4 key programs, 2 in vaccines, 2 in antivirals. Only one of those succeeded, which is the drug Lagevrio. The total spend across those 4 programs is a little over $2.5 billion.
So you spent $2.5 billion. You got one across the finish line, an antiviral. Is that being used in the United States?
Very little. It has emergency use authorization. It never got to full approval, and so we're actually seeing it being used much more outside the United States.
So in actuality, you spent $2.5 billion and got none of significant market share in the United States despite that. Mr. Wado, I'll talk to you for a second. In my 25 years taking care of patients, we were always able to find a solution for their drugs that they needed. 340B programs, rebates, there's always exceptions to the rules, but what type of efforts does J&J make to work with 340B programs and to help some of these people that need help?
Thank you, sir. We care deeply about patient affordability, but also we care about the sustainability of the rural hospitals and small hospitals that take care of patients that are underserved. So we believe that the 340B program, it's an important program to support those hospitals, and we are fully looking forward to collaborate with them in any way we can to support past patient access on those hospitals.
And I'm going to point out once again, it's just not rural hospitals, it's our community health centers are taking great advantage of the 340B program as well, trying to make sure that every patient in America has access to primary care, true affordable access to primary care, plus having access to affordable drugs as well. I might make a couple quick points. The people of Kansas sent me here to save Medicare. To save Medicare, I need a miracle drug to treat Alzheimer's. It seems to me that Americans bear the burden of most of the R&D in this world, and other countries benefit from it. And that impacts the price in many ways as well. Mr. Davis, am I wrong? Why does it feel like to me that Americans are feeling most of the brunt of the R&D cost, or is that not accurate? I don't know.
Well, I think, Senator, it gets down to, as you look across the globe, different markets, and I appreciate what the U.S. does. I think the U.S. favors innovation. It values access for our patients, fast access, most access. Many markets around the world don't do that. What they focus on more is their budget and how do they meet those budget needs, and we appreciate the budgetary constraints that everyone faces. But as a result of that, often patients aren't getting access to meds. They don't get them as fast, which we've commented on today, and it's harder to see how you can support the innovation we need to do in that situation.
Thank you. Senator Baldwin.
This is all a scam. I mean, we got people that's getting ready to retire that's going to try to live off $2,000 to $3,000. impossible. It's impossible. Because what happens, it comes up here, we spend it. We're 35 trillion in debt. We don't have union money. We're dead broke. And then taxpayers have $2 trillion in credit card debt. We are in huge trouble. In this body, we had better start figuring that out, because we're going to have a run on this city here soon, and there's going to be about 150 million people coming up here saying, where's our damn money that we paid in? I could have put my Social Security money, 40 years, in tax, in the market, and probably be worth 8 to 10 million today. But the federal government wasted it. So I'll get off my horse there. But it's good that we have this, because we got, you know, I get a little pension check from education. I was part of a union. It's not going to help people. People are going to have to work, continue to work longer and longer. Am I right, Ms. Gender? Can you say something about Social Security and it being taxed for some reason? We're taxing people for the second time on Social Security that they put into an account.
Yeah, and I'd like to point out when Social Security was first founded, those who established it, it was started out as a 2% tax, and they said this will never take more than 6% of your income. Today it takes 12.4%, and depending on whether you go with CBO or Social Security trustees, it needs to take between 15.8 and 17.5%. So we're talking about thousands of dollars more per year. It also was actually only originally recommended that the tax be up to $66,000, equivalent in today's dollars of earnings. But over time, it has expanded massively, and the money has been spent every year. So whereas everybody thinks this money's been set aside for me, no, for the past 13 years, every dollar that has gone out of workers' paychecks has gone immediately to pay promised benefits. And that's what happens when you have a system that enables those in charge of it to spend the money in the immediate term and leave the buck to the next generation that's coming along. And because Social Security has grown so much, it's actually to the detriment of lower income workers in particular, who have to pay such a large share of their paycheck to Social Security, they have little left to save for retirement. And then lower income and African American workers have the lowest life expectancies. So they are the most likely to get nothing back in return. 1 out of 4 African American men will die between the ages of 45 and 64 after having paid into this system for decades, tens if not hundreds of thousands of dollars, and they might get nothing back.
What's the solution?
I think we ultimately have to shift towards a universal benefit system. That's what true social insurance is. It does not make sense that we are paying the biggest benefits to the highest income earners. So gradually over time, I think we need to bend down the benefits for the middle and upper income earners, actually increase them for the lower income earners, look at things like indexing retirement age to life expectancy, more accurate inflation index, and I think that workers need an option to have their money in something that actually earns a positive rate of return and that can't just immediately be spent by Congress.
I have a 28 and 29-year-old, 2 boys, got a job, working hard, paying Social Security. They ask me all the time, Dad, will I ever see any of that money? Will they see it?
I think they will see some of it. That's the exact same thing I hear whenever I ask a group of younger workers, and none of them raises their hand. So I think that there will be something there, but it's not going to be what has been promised.
Mr. Stevens, you got anything to add to that?
Thank you, Senator. What I would add is when we talk about Social Security or we talk about pensions, the two things that they both have in common is that guaranteed income. You know what you're going to get, generally speaking, at the end of it. What I reference in terms of protected retirement, we have developed now solutions that get at both of those in a very efficient way, and they also address the issue around market volatility because we have step-ups and lock-ins, and it's a very efficient way to deliver that to millions of Americans that we've been talking, and that's all because of what you all did around Secure Act 1.0 and 2.0. They have put us in a position to do that, and that's why I'm really encouraging us to have every 401k plan, 457 plan, 403b plan at least one of those solutions so that the American workers can choose. If they want to know what they're going to get in retirement, we can deliver that for them.
Young people of all ages ask me, why can't we put our money in our own 401k instead of putting it in Social Security? Is there an answer to that?
I think what I love is that they're asking the right question. Savings in any way is a good thing, and I think there's a place for Social Security, there's a place for pensions, and there's certainly a place for what we're doing in 401k plans.
Thank you.
Senator Hassan.
Thank you.
Now we'll begin with the questioning. You know, at hearings like this, experts throw out a lot of numbers, and I look at the world a little bit differently than some of our conservative economists in terms of what's happening to working families. But at the end of the day, you got millions and millions of people who have worked their whole lives, are entering retirement, and they're scared to death. And I think, Ms. Chambers, your testimony was extremely moving, because I think you're not just speaking about your own life, or not even about the UAW and union members. You're talking about millions and millions of people. Talk a little bit, not only for your own experience, from your friends, your family, what it's like to have worked, in your case, 17 years for one of the major corporations in America, and as I understand it right now, you have no retirement program, no pension program. On an emotional basis, on a personal basis, what is that like?
So, yeah, we have a 401k, and we got a raise in our 401k, and it's great. It's a good stepping stone. It's a good foot forward. But when I retire, my 401k is based off, and the rest of America now that's in my generation, is based off of what the stock market's doing. I've seen several times in my lifetime where the stock markets went down, and we've lost a lot of money in our 401k. I'm not at retirement age, but when I look at my 401k and the amount of money that was bleeding out of it with the COVID, it makes me very uneasy. It kind of feels like, especially working at Ford. I had a goal post when I first hired in, and then it was, well, you're a temporary employee full-time until further notice. So then now
Explain to members what being a quote-unquote temporary, you were a temporary employee for 6 years, right?
Yep.
It's a long temp. What does that mean?
So I was considered full-time, so I worked 40, 50, 60 hours a week, but I was locked in at $14 an hour until 2013. And I was expected to do everything a full-time employee did, but I didn't get any of the benefits. And that actually, when I hired in, I questioned what parts of the contract I fell under, and they said, it depends on what we're talking about. So there was never any full, like, here's your book, this is your rules and regulations. It's like, no, we're not going to cover you under that.
Okay. Thank you. Thank you very much. Ms. Ghilarducci, we are, in one sense, the wealthiest country in the history of the world, right? Yeah. A lot of billionaires out there doing very, very well. How does, in your judgment, the American retirement plan, the status of older Americans compared to people around other wealthy nations?
Yeah.
Microphone.
My data really looks at that question. So I compare what people were like when they were approaching retirement 30 years ago, and then take the same snapshot of the generation that looks like them right now. And as I said in my written testimony today, 50% will not be able to meet their retirement standards, and most of them won't be able to meet poverty standard. Compare that to other countries with all different kinds of systems, the Scandinavians, the Germans, the French, even the Italians. Just look at our peers, and we fall way behind. I was looking at the elderly poverty rates. Kazakhstan does better than us. So there's a couple of design issues.
I heard from some of the economists here today that we're doing just great. Things are getting better. Is that
true? So that was my little lesson on averages versus medians. Because the rich have done so well, they have brought up those averages that people who talk about average retirement wealth can point to. It's gone up. But that's because the top 10% got the benefit of retirement tax cuts. They got the benefit of the run-up in the market. They didn't take money out, to buy their houses.
Okay, last question. Thank you very much. Sorry. Mr. Doonan, right now, billionaire pays Social Security taxes on $168,000. That's about it. Massive amounts of untaxed money there, despite massive income and wealth inequality. That makes sense to you?
Thank you for the question.
Microphone.
Thank you for the question. I would note that one of the reasons Social Security's financing fell off track is we used to capture 90% of total income, and that was sort of expected to continue. But with rising inequality, I think we're down to about 82 or 81. When these projections were done, in the early 80s. I feel like they did a pretty nice job. We had 40 years of level costs. But there are some areas where the projections just didn't come true.
Senator Cassidy?
Committee consider the Paul substitute amendment as modified to S3664 as the underlying bill. Seeing no objection, so ordered. Senator or Ranking Member Paul.
I want to thank Chairman Peters for working with us on this. I think distrust in public health officials is at an all-time high, and one way to restore trust is to make sure that public policy isn't influenced by personal gain. We do this at almost every other level of government. You know, if you're on the city council and you own a textbook company and you're voting for textbooks for the local school, you usually have to reveal that you're getting money, you know, your company is up for a bid. Usually you recuse themselves. And so this will just allow more information to be seen by the public to make sure that people receiving money aren't actually making decisions mandating certain things from the companies they're receiving money from. We do know that through Freedom of Information, 315 NIH scientists received, 1,500 scientists received over $300 million in royalties. And right now, that it's not being reported, and we would love to see it publicly reported, and we're happy to have worked with the chairman on this bill.
Thank you, Ranking Member Paul, and thank you for your leadership on this legislation. If there is no further debate or amendment, the question is on final passage of S3664 as amended. The clerk will call the roll.
Senator Carper. Aye. Senator Hassan. Aye. Senator Sinema.
Aye by proxy.
Senator Rosen. Aye. Senator Ossoff. Aye. Senator Blumenthal.
Aye by proxy.
Senator Butler. Senator Paul.
Yes.
Senator Johnson.
Aye.
Senator Langford. Senator Romney.
No by proxy.
Senator Scott. Aye. Senator Hawley. Aye. Senator Marshall. Aye. Senator Peters.
Aye.
Mr. Chairman, on the vote of those present, the yeas are 12, the nays are 0. On the vote by proxy, and for the record only, the yeas are 2, the nays are 1. In this vote, the yeas are 12, the nays are 0, and the motion is agreed to.
The motion is agreed to. I want to thank all of my colleagues for your attendance here and for a quick markup that concludes our voting. But does any member?
We have a very knowledgeable panel, and we thank all 5 panelists for being with us today. We're going to begin with Sean Fain. Mr. Fain is the international president of the United Automobile Workers. He is a 29-year member of the UAW and got his start with the union as an electrician at Chrysler Kokomo casting plant. Recently, he led the UAW in negotiating an historic contract which substantially raised wages and benefits for the workers of that union. Mr. Fain, thanks for being with us.
Good morning, and thank you, Chairman Sanders, Dr. Cassidy, and members of the committee. I'm here to talk about one of the most important issues to any union leader and any working class person, any U.S. senator, and any human being, and that's our time. You know, as president of the United Auto Workers, I represent 400,000 working class people and 600,000 retirees. And I know when my members look back on their lives, they never say, I wish I would have worked more. When people reach the end of their lives, they never say, I wish I had made more money. What they wish for is they wish they had more time. And that's what work does. You know, work, we are paid for our time. And when we work, we are sacrificing time with other people, with family, friends, and other things we wish to do. You know, but time, just like every precious resource in our society, is not freely given to the working class. Since the Industrial Revolution, we've seen productivity in our society skyrocket. With the advance of technology, one worker is now doing what 12 workers used to do. More profit is being squeezed out of every hour, every minute, and every second. There was a time when this phenomenon was supposed to lead to workers getting their time back, getting some of their lives back. Nearly 100 years ago, economist John Maynard Keynes spoke of the future of workers' time. His worry that was with all the gains in productivity, we wouldn't know what to do with ourselves, and he predicted a 15-hour work week 100 years ago. You know, in my own union, I go back into our archives and I read about the fight for the 30-hour work week, an idea that was alive and well with our union back in the 1930s and 40s. But today, deep in the 21st century, we find these ideas unimaginable. Instead, we find workers working longer hours. We have workers working 7 days a week, 12 hours a day. There are workers, not union or not, working multiple jobs. And they're living to work, and they're scraping to get by, and they're living paycheck to paycheck. You know, we find workers today, later in their life, working deep into their 60s, 70s, and 80s because they can't afford to retire. And we find associated deaths of despair from addiction and suicide, of people who don't feel a life of endless, hopeless work is a life worth living. You know, we have workers who feel despair as a consequence of advances in technology. Workers have been sacrificed at the altar of greed, and they've been stripped of their dignity. We have a mental health crisis we talk about a lot in this country, but we never talk about the causes of that. You know, there's been studies done, you know, increases in stress from working 7 days a week, 12 hours a day, you're sacrificing family life, things you want to pursue. It causes an increase in cortisol levels, which lead to heart disease, cancer, strokes. You know, but given all those facts, if someone is lucky enough to get to retire, typically when they've worked themselves to death their entire life, they face knee replacements, hip replacements, shoulder surgeries, and the rest of their lives figuring out how they're going to survive. So, you know, it's sad to say that in 1933, the U.S. Senate passed legislation to establish a 30-hour work week, but due to intense corporate opposition, that legislation failed. But in 1940, President Franklin Delano Roosevelt signed the Fair Labor Standards Act, establishing a 40-hour work week. 84 years ago, the 40-hour week was established. And since then, we've had a 400% increase in productivity, but nothing's changed. You know, that was why we had in our Big Three campaign, we had our stand-up strike. We raised the flag for a 32-hour work week. This isn't just a union issue, contrary to what some people want to talk about. This is a working class issue. And that's why 75% of Americans in our contract fight stood with us in that fight, because they're all living the same reality. You know, who's going to act to fix this epidemic of lives dominated by work? Are the employers going to act? Will Congress act? You know, how can working class peoples take back their lives and take back their time? And I know what people, and many in this room will say. They'll say, people just don't want to work, or working class people are lazy. But the truth is, working class people aren't lazy, they're fed up. They're fed up with being left behind and stripped of dignity as wealth inequality in this nation, this world spirals out of control. They're fed up that in America, 3 families have as much wealth as the bottom 50% of citizens in this nation. That is criminal. America is better than this. So I want to close with this. I agree there is an epidemic in this country of people who don't want to work. People who can't be bothered to get up every day and contribute to our society, but instead want to freeload off the labor of others. But those aren't blue-collar people. Those aren't working-class people. It's a group of people who are never talked about for how little they actually work and produce and how little they contribute to humanity. The people I'm talking about are the Wall Street freeloaders, the masters of passive income. Those who profit off the labor of others have all the time in the world, while those who make this country run, the people who build the products and contribute to labor, have less and less time for themselves, for their families, and for their lives. So our union's going to continue to fight for the rights of working class people to take back their lives and take back their time. And we ask you to stand up with the American workers and support us in that mission. Thank you.
The Senate Committee on Health, Education, Labor, and Pensions will come to order. This has been a shortened week, so I think you're going to see there are hearings taking place all over the place, and I think you're going to see senators drifting in and out. But I want to thank all of our panelists for being with us. This morning, we are going to be talking about an issue that is very rarely discussed in the halls of Congress or the Senate, and that is the need to reduce the standard work week in the United States. In fact, the last time, as we understand it, the Senate held a hearing on this subject was in the year 1955. So I think maybe the time is now to renew that discussion. At that hearing, the Senate heard from Walter Reuther, who was at that point, the head of the United Auto Workers and the Congress of Industrial Organizations, and Reuther was regarded as one of the great labor leaders of his time. And this is what Walter Reuther said at that time. He said, quote, "We fully realize that the potential benefits of automation are great, if properly handled. If only a fraction of what technologists promise for the future is true, within a very few years, automation can and should make possible a 4-day work week. The reduction of the work week to 35 or 30 hours in the coming decade can be an important shock absorber during the transition to the widespread use of automation. It can both reduce the impact of sharp rises in output and increase the manpower requirements in industry and commerce." End of quote. And yet today, nearly 70 years later, despite an explosion, as we all know, in technology and a massive increase in worker productivity, nothing has changed. Think about that. Think of the huge transitions we have seen in the economy, but in terms of the work week, nothing has changed. While we have not discussed this issue for a long time in Congress, this is not, needless to say, a new issue. In 1886, one of the central planks of the trade union movement in America was to establish an 8-hour work day with a simple and straightforward demand, quote, 8 hours for work, 8 hours for rest, 8 hours for what you will, end quote. That was back in 1886. Americans of that era were sick and tired of working 12-hour days for 6 or 7 days a week with very little time for rest, relaxation, or quality time with their families. They went out on strike, they organized, they petitioned the government and business owners, and they achieved real results after decades of struggle. In 1916, President Woodrow Wilson signed legislation into law to establish an 8-hour workday for railroad workers. 6 years later, the Ford Motor Company became one of the first major employers in America to establish a 5-day work week for auto workers. And here is something I believe that most people in our country do not know. In 1933, the United States Senate overwhelmingly passed legislation to establish a 30-hour work week by a vote of 53 to 30. That was 1933. While that legislation ultimately failed as a result of intense opposition from corporate America, a few years later, President Franklin Delano Roosevelt signed the Fair Labor Standards Act into law, and a 40-hour work week was established in 1940. My friends, in 1940. Unbelievably, 84 years later, despite massive growth in technology and worker productivity, millions of workers in our country are working longer hours for lower wages. And I hope people hear this, because it's not an issue we talk about enough. Today in America, 28.5 million Americans, 18% of our workforce, now work over 60 hours a week, and 40% of employees in America now work at least 50 hours a week. We were talking about a 40-hour work week 80 years ago, and that's what people today, despite the explosion of technology, are working. The sad reality is Americans now work more hours than the people of any other wealthy nation. And we're going to talk about what that means to the lives of ordinary people. In 2022, employees in the United States and I hope people hear this, logged 204 more hours a year than employees in Japan, and they're hardworking people in Japan. 279 more hours than workers in the United Kingdom, and 470 more hours than workers in Germany. Despite these long hours, the average worker in America makes almost $50 a week less than he or she did 50 years ago after adjusting for inflation. Now let that sink in for a moment. Think about all of the extraordinary changes in technology that we have seen over the last 50 years. Computers, robotics, artificial intelligence, and the huge increase in worker productivity that has been achieved during that time. In factories and warehouses, robots and sophisticated machinery did not exist then, or were only used in primitive forms. In grocery stores and shops of all kinds, there were no checkout counters that utilized barcodes. As a result of the extraordinary technological transformations that we have seen in recent years, American workers are now over 400% more productive than they were in the 1940s. Extraordinary. Technology has made working people far more productive. And what has been the result of all of that productivity increase for working people? Almost all of the economic gains of that technological transformation have gone straight to the top, while wages for workers have remained stagnant or even worse. While CEOs today are making 350 times as much as their average employees, workers throughout the country are seeing their family life fall apart as they are forced to spend more and more time at work. They're missing their kids' birthday parties, Little League, baseball games, and just the time they need with their family. And what stresses them out even further is that after spending all of this time at work, many of them still are living paycheck to paycheck, can't take care of their basic needs. At a moment in history when artificial intelligence and robotics, and I hope we all understand that the jobs that people have today ain't going to be there in many cases in 15 years. Our economy is going to be transformed through artificial intelligence and robotics. The question that we are asking today is a pretty simple question. Do we continue the trend that technology only benefits the people on top, or do we demand that these transformational changes benefit working people? And one of the benefits must be a lower work week, 32-hour work week. This is not a radical idea. France, the 7th largest economy in the world, has a 35-hour work week, and is considering a 32-hour work week. Norway and Denmark is their work week is about 37 hours, and Belgium has already adopted a 4-day work week. And what we're going to hear today is there are companies all over our country and all over the world that have adopted the 40-hour work week. And you know what they found? They found that productivity actually went up because workers were able to focus on their work. They were not exhausted. They were happy to go to work. So the issue that we are talking about today is of enormous importance. Who benefits from the exploding technology? The wealthiest people who are doing phenomenally well, or working people who are falling behind? And with that, Senator Cassidy, do you want to introduce your witnesses?
Please. First, Dr. Liberty Vittert is a professor of the practice of data science at the Olin Business School at WashU in St. Louis. She's a senior fellow at Harvard University and MIT researcher, on-air statistician for News Nation, 2's Discovery Channel shows, and analyzes and calls elections for Decision Desk HQ, and is featured in a number of publications, has a great resume for academics. But what is most interesting about Dr. Vittert is that she studied at Le Cordon Bleu. So we actually have someone here who knows how to cook something more than pancakes, which, no offense, I'm sure others do as well. Anyway, so you would call it a crepe. Anyway, so we're pleased to have you.
Cookies for the group. Chairman Sanders, Dr. Cassidy, Senator Hickenlooper, thank you so much for having me here today. I am a statistician, and we have heard a lot of statistics thrown around. So I'm here to make some sense of these and make sure we're analyzing them properly. Proponents of the 32-hour work week often point to statistical studies, mostly pilots, that suggest shorter work weeks can lead to increased productivity and improved employee well-being. But this argument is making broad claims based upon weak and statistically flawed data sets. A closer look at some of the most popularly cited studies reveals significant flaws and limitations. We'll take a brief look at some of these studies to understand these statistical flaws and shed significant and potentially insurmountable doubt on the proposal's sustainability in the American work economy. Many of the news headlines touting these studies discuss the stress or happiness levels of workers who work less time. Inevitably, over the short term in these short pilot projects, it's not inconceivable to imagine that happiness levels increase. The question is, where does the pendulum end? At no work. Statistical studies, long-term statistical studies of this, have shown us that happiness does not increase over time. It goes back to the same level. For example, the study in France, after mandatory government reduction of hours, saw a return to the same level of happiness after 7 years. And if you want to see those same employees really stressed out, just see what happens when their employers lay them off to hire part-time workers instead, or have to close their doors because they cannot make enough revenue. Another major flaw in these studies is the self-selection bias. For example, the companies that choose to participate in some of these studies, like the 4-Day Week Global Study, are companies whose work tend to be able to be adapted to a shorter work week already, who can remove, quote, wasted hours. It is specifically only companies that are able to adapt to shorter work week that tend to participate, cutting out, as they say, extraneous meetings, coffee breaks, having more independent work, going to Zoom. However, over 70% of the US job economy is people working with their hands. They don't necessarily have extraneous meetings or too many coffee breaks to cut out. So statistically, you can't apply this type of cutting of hours across the entire economy. Also, given the types of companies that are potentially capable of cutting their work week, we could see a divide of the rich getting richer, having more time, and the poor needing to take on 3 part-time jobs in order to pay the bills. We also potentially disadvantage older workers who cannot necessarily physically do the same amount of work in a shorter time. This happened to the great detriment of that population during the Great Depression. In terms of increased productivity, by shortening the week, the statistics just aren't there, and there are specific studies that show the opposite. Japan tried it, as Dr. Cassidy said, from 1988 to 1996, and the result was not ambiguous. Economic output fell by 20%. Another largely touted study was in Iceland, which had a pilot program cutting the work week by about 4 hours from 2015 to 2019. The results were blasted all over the headlines as this overwhelming success. What is not reported on is that the Icelandic government, or rather taxpayers, now have to shell out almost $30 million extra a year to hire more healthcare workers because of this experiment. In Spain, where there's a pilot program, the companies that participate get access to a multi-million-dollar government fund in order to participate. Microsoft also tested a 4-day work week by shutting down its Japan office every Friday for the month of August. The statistical claim is that this resulted in a 40% increase in productivity. This is a statistical fallacy, that correlation is not necessarily causation. Productivity increased over a very, very short period of time during a low productivity month when overall productivity was already at a 75-year low. There is no statistical evidence to merit a nationwide mandate of a 32-hour work week. And in fact, there's clear evidence against it. If it works for some companies in some sectors, that is great. But it cannot be applied to all sectors. Thank you.
I really appreciate it. Mr. Secretary, you've said by helping rural hospitals stay open, we are helping residents of rural areas get the care they need close to home. Having access to care nearby is not only more convenient, but it also lends to better health outcomes and boost local economies. I want to say I couldn't agree with you more. I certainly hope that you mean that, and I assume that you would confirm that you do.
Yeah, and any ideas you have, because there are a lot of healthcare facilities in rural America that are on the verge of closing.
Yeah.
Once they close, it's tough to reopen, so we're more than willing to work with any of you who are interested in that.
That is wonderful, because that's actually the commitment I want from you today. We, as you know, there are a very small number of new rural hospitals that opened in 2020 just before the country shut down, and one of these hospitals is actually located in Alabama. So Thomasville Regional Medical Center was among the unfortunate few who were deemed ineligible for provider relief funds due to the formula's reliance on the figures from 2019, and you're well aware of this, as you know.
Yeah.
Throughout your tenure, many of my colleagues, Representative Sewell there on the other side, in the other chamber, and on the other side of the aisle, has talked to you about this and has asked for your commitment in budget hearings just like this, and received it, to working with us to find solutions for this group of needy hospitals. These members received a commitment from you and their offices to ensure that these hospitals received proper federal assistance via the Provider Relief Fund. And so my assumption is that you stand by that testimony. And my question would be, what action did you take to ensure Thomasville Regional Medical Center received adequate provider relief funds?
Thomasville, like many of the facilities that have applied, have to meet the criteria that Congress set forth for us to be able to fund them with the provider relief dollars that were made available. Where we had some flexibilities, some discretion, we took them to try to help some of the facilities that were clearly hurting and in desperate need, especially those that were providing services to folks who are in underserved areas. But our discretion, our flexibility is limited by what Congress set forth as the guidelines for distributing the dollars. Too many facilities, and I suspect Thomasville being one of them, fell within that scope where it became difficult to reach them because of the criteria.
So what do we do? I mean, because there has to be a pathway to help, because just as you mentioned, they are on the verge of closing. And if you look at some of the things that we've seen, they have kind of, the Harvard School of Public Health put out that this congressional district has the lowest life expectancy in the country. And so if we are not going to help hospitals like this that provide people access to care within their communities, your very first statement that I wholeheartedly agree with, then what are we doing? I mean, this is what we're here for. So you're telling me why we can't. Tell me how we can. That's what I want to know.
Yeah, and we can if you all hadn't swept up close to $5 billion that we had in COVID relief dollars, we could have perhaps come to you and asked for you for more flexibility to use some of that money for some of those providers under the Provider Relief Fund. We're out of money in the Provider Relief Fund.
So there was about $7 billion left, right? Is that right?
At this stage, no.
Right, but when that occurred?
Left in the sense that it had not yet been obligated, but it was already destined to go to provide different services. It was then swept up by Congress, and now it's no longer available.
So what can we do?
Well, you can always try to re-up the provider relief.
Well, no, I mean, what can you do in your role right now? What can you commit to me to help keep this hospital open? Or what resources are available? What thought process do you have? You obviously sit in the big chair, so don't tell me what you don't have. Tell me what you do have and how we can get that to a path of success.
Well, the problem is if I don't have the resources to make things happen, there's only so much I can tell them we can do, because what they want is money. They're not interested in smiles, they're interested in money. If I don't have money in my pocket, you all swept it up, it makes it tough for me to offer.
Do you have
money.
any money that could work to go towards that at all?
Senator, as you know how the way things work, you tell me where I can spend the money.
Okay, so what would I need to advocate for right here in this budget to help move that forward?
There's two things you can do. Pass legislation that gives us more flexibility in using some of the money you've already given us, which probably would gain some opposition from folks who say, wait a minute, that's already money that we're going to use and you're sending it off to somebody else, so you're going to have to deal with that. But you could do that, give us more flexibility with money we do have, which we don't have flexibility to use, for example, with a program like Thomasville. Or you can re-up a program like the Provider Relief Fund that has some resources so that when Thomasville comes to us, I can say, we now have some resources that we can provide to you.
Will you commit to continuing this conversation with me, the two of us?
Absolutely.
Thank you.
Senator Shaheen, had you just come in? If you'd like to go first, that's fine.
Sen-
Okay, thanks. I'd like to talk about the World Health Organization, if we could. The Biden administration has vowed to reform the World Health Organization, but it threw away its leverage early on, in my opinion. The administration, against the advice of many, rejoined the World Health Organization, gave it $200 million without insisting on a single reform. In a few weeks, the administration is expected to commit the United States to 2 international agreements that would expand the World Health Organization's authority during a global pandemic. Last week, I joined my Republican colleagues in calling on President Biden to reject these agreements, what I believe are harmful. Yesterday, the UK announced that they will refuse to sign the World Health Organization's pandemic accord, saying that they will only support the adoption if it is firmly in the UK national interest and respects national sovereignty. December 13th last year, during a hearing held by the Select Subcommittee on the Coronavirus Pandemic, you said, quote, "This administration is firmly committed to ensuring that the World Health Organization implements a comprehensive set of organizational reforms, particularly to strengthen its governance, its budgetary and financial management processes, and to improve oversight to strengthen the organization's efficiency and effectiveness." You know, instead of focusing on reforming the World Health Organization, the administration is choosing to hand over U.S. sovereignty to them. We are the United States, not the United Nations. So the question is, do you commit to ensuring that U.S. sovereignty is not infringed upon?
Senator, let me respond in the affirmative. Absolutely, the sovereignty and security of the United States will not be undermined in this negotiation process. We have been very insistent that there are 2 articles in the pandemic accord discussions that I would like to just reiterate. Article 3 states clearly that WHO has no authority over sovereign states. Absolutely not. Article 24 of that same negotiation further expands, and it states clearly that neither the Secretariat of WHO nor the Director General has any authority over any sovereign state in the areas of dictating, telling them what to do in terms of mandate use of any tools, including vaccines, mass, lockdown, etc. I think it's absolutely very clear in Article 24. We will oppose any attempt or any perception of that accord that seeks to undermine or is perceived as going to undermine the sovereignty of the United States. I will just end, Senator, by saying that the sole purpose for us in the discussion is to protect our national interests, And there are 3 things that we are seeking to achieve in this negotiation. One is to ensure that we have capacity globally that can allow us to easily detect, prevent, and control and respond to disease outbreaks. As we know, a disease outbreak anywhere in the world becomes a threat right here. 1 million Americans died because of COVID-19. Secondly, is to ensure that we have access in a timely fashion to biologic materials, including specimens, data that will allow us to develop vaccines, therapeutics, and diagnostics that will protect us. And lastly, the ability to distribute those resources in an equitable manner.
So following the UK's announcement just yesterday about their refusal to sign, is the UK alone able to block the passage of the accords? Or if not, how many other member countries would need to oppose it in order for the accords to fail?
The accord, Senator, is still being discussed, including as of this morning, about several issues, especially areas related to intellectual property, technology transfer, pathogen access and sharing, as I indicated. This accord has been going on, the discussions, for about 2 years. So we remain hopeful that countries that are discussing will see value in our collective security and learn the lessons, as Chairman said, of what COVID taught us about our common vulnerability. So we just don't know exactly who is going to oppose it or not, but we have to show our leadership. As I said in my introduction, this is the moment for us to show the leadership. We have been a global health leader over the years, and this is not a moment for us to relent our leadership.
Mr. Chairman, can I have one quick last question, and it's to Ms. Kelly Adams Smith. Moldova's recent, almost exclusively reliant on Russian energy. Tuesday, Norway and Moldova signed an agreement to tighten cooperation in their energy sector. Can you tell me the current status of the Moldova's energy grid?
Thank you very much for the question, Senator. It is true that Moldova was 100% dependent on Russia for its energy sources. After the Russian reinvasion of Ukraine, it became clear that that was no longer possible. And the Moldovan government, with assistance from the United States and European allies, has made some successes in becoming less dependent. The energy grid, the electricity grid of Moldova is now hooked up to the European grid. USAID is funding an electrical line between Romania and Moldova, and Moldova is now also buying for the first time non-Russian gas, which is an incredibly positive development.
Thank you, Mr. Chairman.
Senator Cassidy, I'll allow you closing remarks, and I have not yet voted, so keep it short. Go ahead.
First, I'd like to ask unanimous consent to enter into the record an op-ed written by Kelly Crawford, founder and executive director of Able Speaks, an organization created in memory of her son who was diagnosed with trisomy 18. The organization supports families. I think they would feel just as Senator Kane. They feel as if the children who are born with trisomy 18 are being selectively aborted, and that, of course, makes them feel like their lives are threatened. Dr. Verman, just a quick question. You rightly point out that rarely is this done. Would you agree, therefore, that it would be reasonable to restrict late-term abortions?
So first, late-term abortion is not a medical term. We tend to say abortion later in pregnancy.
Would you find it reasonable that after some week that it would be reasonable to restrict an abortion after a certain period of week, given that, if this is the life of the mother and such like that? Because I think that's really the crux. Is there any kind of limit that will be placed? If you say this hardly ever happens or never happens, I think was your words, would it be reasonable then to restrict when this would occur?
When I provide abortion care later in pregnancy, I want you to envision a patient who has a nursery designed, a name picked out,
and we have to. I'm just saying,
who is diagnosed with a terrible fetal anomaly
but that
or
is
a worsening
the issue.
health condition.
This is not a theoretical. I'm just saying, if the child is otherwise well and the mother's health is well, since you say this hardly ever happens, is it reasonable to have
I will say abortion at the moment of birth does not happen. I also take care of patients who need abortion care later in pregnancy for many different reasons.
And I respected, by the way, I really did respect you speaking of that tension between the week 23 that you would abort and the week 23 that you would resuscitate. I think you're avoiding, I don't mean to be confrontative, but you're avoiding the dialogue here.
No, I totally hear you, and I'm not trying to be confrontational. I'm just trying to highlight what these situations actually look like. So, for example, I did an abortion care later in pregnancy for someone.
I'm not going to get an answer to that, but and Dr. Francis, will you just finish up on that question, please?
Absolutely. Well, I think certainly beyond the point where a child can survive outside of his or her mother, there would never be a reason you would need to intentionally end that child's life. You'd simply deliver that baby, you'd take care of mom, and you'd take care of baby in an appropriate way. And I think that that's something that I would hope that all of us at this table could agree upon.
With that, I yield. Thank you.
Okay. I just...
Let me just give Dr. Vernal, I don't think that Senator Cassidy gave you the opportunity to respond effectively. Take 2 minutes to respond and say what you wanted to say.
I appreciate it. I was just trying to paint a picture as a doctor who's actually sitting with these patients and providing this full spectrum of care, what this care actually looks like. So when I'm providing care for a patient, for example, that comes in later in pregnancy, a lot of times that's a patient who's received a terrible fetal diagnosis and is having to make that difficult difficult decision. They have a nursery set up, they have a name picked out, and what they need from me as their doctor is support. I have some patients that choose to continue that pregnancy and deliver at term, and other patients who say that's too traumatic, I can't do that. And my job is to support them in both of those situations with whatever is right in their life. I think as doctors, we all recognize that providing life-saving care sometimes means ending a pregnancy, and to call that care something besides an abortion is an issue of semantics to further a political agenda. And so the care that we're referring to that sometimes means ending a pregnancy, that is abortion care, and that is what we are talking about here, and is sometimes necessary life-saving care for our patients who come in needing this care for a variety of reasons.
Thank you for that comment, and so I will turn it to Senator Cassidy.
And I'll defer to Senator Mullins.
Thank you, and thank you, Chairwoman. I just want to actually commend everybody for actually having a good conversation here. I expected this to actually be pretty rambunctious, and so for that, I'm probably going to leave a lot of my questions out because I really did. I came here to be punchy. And instead, I think it's important that I share a story, and then I do have a couple questions too, because I do appreciate everybody's opinion, and that's what this is about having a conversation. And I think put in a context of why I'm so pro-life may help a little bit of the understand our positions, right? I've been married for 27 years. I got married when I was 19. My wife was 18. First question my father-in-law asked me when I asked to marry my wife, Christy, is she pregnant? And I was like, no. I don't think so. And it's 7 years later, we were still trying to have kids. And my wife had endometriosis, and it took a long time to have kids. We went through everything you can think of, in vitro, through shots, through, you can imagine. And then she got pregnant, and that was my Christmas gift one year. I got it out of my stocking. It was quite an exciting time. And we went through the pregnancy, we went to the first doctor visit, and how excited it was. And then we went later on, and we heard the heartbeat the first time. And I'm going to tell you, that was a child to me. I mean, I was so excited. We were thinking of names. We were going through the whole process. And man, I can't tell you the excitement I heard. I literally, I'm not even a crier at that time. Now I talk about my kids, I cry all the time. But I remember getting emotional for the first time. And I was thinking, what is this inside of me? A tear about ready to drop out of my eyes. But then while through the pregnancy, she went back in and she had a miscarriage. That was a death to us, 100% death to us. So no one will say that wasn't a death to us. That was a death. That was a child when I heard the heartbeat, and it was a death when we didn't hear the heartbeat. And it was extremely difficult for my wife and I. Fortunately, literally the month that child was due to be born, we found out we were pregnant again. And his name's Jim Martin Mullen, named after my dad. 15 months later, we had another one because people that tell you can't get pregnant when breastfeeding lies, because you can. And his name's Andrew Daniel Mullen. 3 years later, after the doctor said she couldn't get pregnant anymore and she was going to have a hysterectomy, we had another one. And her name is Lara. She's 15, Lara Dell Mullen. And Lord, she's 15. And love her to death. And then my wife and I decided we wasn't going to have kids anymore. And I got a vasectomy, and she got an ablation. And yet we still collected 3 more kids. Because there was 3 kids that deserved a home and 2 mothers that loved those children so much. Instead of aborting them, they were brave enough to carry them and gave Christy and I an opportunity to love these 3 wonderful kids. 2 twins named Ivy and Lynette that we'd adopted when they were 2 years old, and now they're 13. And Jace, who is wrestling at Oklahoma State as we speak. I was in Ohio with him this week, and his mother was just barely 20 years old, and the twins' mother was 15 when she got pregnant. And I thank God every day, literally every day, that those mothers gave Christy and I an opportunity to be blessed and be loved by these 3 kids. And so there's options. What's sad is when you look at statistically speaking is that over 50% of the pregnancies inside the United States is unplanned. But 50% of all pregnancies also end in abortion. That's sad. I mean, you're lucky to be born right now. And inside DC is 51.5% of all pregnancies, meaning we end more pregnancies here in Washington, D.C. than we actually have. Something's wrong. Abortion has become almost a point of convenience. While we understand it's unplanned, we get that, but that child deserves an opportunity to be in a loving home just like my 3 kids are. I tell everybody we had 3 we got stuck with and 3 we chose. Which ones do you think we love the most? I'm blessed. Christy and I are blessed. But we got to talk about the reality here. And we're not talking about rape and incest and high-risk births. Those account for less than 9.5% of all births out there. 8% are high risk. 1% are rape. Less than 0.5% are from incest. We're not talking about those abortions. We're talking about others. Guys, we can do better as a country, and that's what this conversation is about. We have to talk about it. Just give these kids an opportunity to live. They'll bless somebody, because our kids bless us every single day. That I yield back.
Thank you, Senator Marshall.
Thank you, Madam Chair. Dr. Linton, how many babies have you delivered in the past month or two?
I would say probably in the 10s to 20s.
Okay. And Dr. Verma, how many babies have you delivered in the past month or two?
That's a good question. I'm terrible at estimating, but over my career, thousands.
But you're still active. You're still actively delivering babies.
Oh, yeah. I do
You have a
labor and
prenatal
delivery
clinic.
shifts every week.
How often or what type of range would you do sonograms on a pregnant woman, let's say before their 4th month of pregnancy? Hardly ever, a lot, sometimes.
So yeah, I see patients with all kinds of pregnancies, and usually when a patient comes in and has a positive pregnancy test, I talk to patients that want to continue
My
those
question is, how
pregnancies.
often do you do sonograms on your routine prenatal visits before 16 weeks or so?
We usually do an initial ultrasound to confirm that the pregnancy is there.
For
to
prenatal
confirm it.
pregnancy, first visit, usually you're doing a sonogram to confirm the pregnancy. Dr. Linton, how often
Depending
are
on
you
how
doing
far
sonograms?
along they are, yeah.
In the first trimester or early second on a routine OB situation?
So to be very clear, I work on labor and delivery and I deliver babies, but I do not provide prenatal care.
Thank you. So then, Dr. Linton, you've delivered a 23, 24-week baby, I'm sure, before?
Yes.
Yeah. When that baby's delivered, you call in anesthesia, you call the NICU, you call everybody you can in to help that baby, right?
Depends on the clinical scenario. But yes, if it's a desired pregnancy and the patient has voiced the desire for resuscitation, then we have NICU present at that delivery.
And you've also done abortions at 23, 24 weeks as well?
In my training, I provide the standard of care in line with medical
I'm
laws
just
for the
asking,
state that I'm living in.
I'm sure you're not ashamed of it. You've done abortions with the babies 23, 24 weeks?
I provide the care that I'm trained to do based on the state laws where I live in.
So, and Dr. Verma, you've done abortions and you've delivered babies at 23, 24 weeks, full resuscitation. At the same time, you've done abortions on those as well.
I think what you're highlighting here is the complexity of what we do.
No, that's not my question. I get to ask the questions here. I'm
complicated.
not asking for a lecture. How do you, is there any distress in your mind or your heart after doing an abortion? On the one hand, you're delivering a baby at 23 weeks and it's full bore, all out, resuscitate the baby. You feel horrible, it doesn't make it. Then you do an abortion on that same, how does that make you feel?
Yeah, no, I appreciate the question. I think it's a great question. And again, like I was saying, this is why this is so complicated. I feel that complexity. Like I said, I've experienced a first trimester loss myself, and I found that loss devastating. So this is complicated, but I also know that my patients are able to make these really complicated
Thank you so much. Thank
decisions
you.
about their health and
Dr.
lives.
Linton, what pregnancy category of drug is mifepristone?
I'm sorry, Senator, off the top of my head, I can't tell you the class.
Dr. Verma, you know what type of pregnancy category drug mifepristone is?
I know mifepristone is incredibly safe based on decades of data.
About misoprostol, do you know what category of drug that is in pregnancy?
I can tell you we use misoprostol for a variety of reasons, including in desired pregnancies on labor and
Understand that.
delivery every day.
So they're both category X drugs, okay? I'm going to tell you the answer. They're both category, so y'all are prescribing these drugs and you don't know what category of drug it is. And why is it a category X drug? because it causes fetal malformations, right? So it causes fetal malformations.
And those
Right.
categories that you're describing are actually based on politics. The mifepristone is safer than Tylenol,
So you're saying the
Viagra,
FDA
multiple.
is based upon politics. The FDA is saying this is a Category X drug. Would you agree with me that these abortion pills are less effective at 14 weeks as opposed to 8 weeks, Dr. Lindman?
Dr. Linton, yeah, I would say that our data does support with increasing gestational ages that sometimes we have to modify the protocol, but generally
effective.
they
They're
are
less
more
effective.
effective at earlier gestational ages
Right.
depending on the protocol you
So what I'm
use.
confused about is and I've never prescribed this drug. I've taken care of lots of patients that have complications from these drugs. I'm confused why you do a sonogram in a routine pregnancy to establish gestational age. That's the main reason you're doing pregnancies in the first trimester, early second trimester, because the spine's not developed, heart's not developed. So you're basically doing it for gestational age. You're recognizing that so many women come in and they're a month off of their gestational age. So why wouldn't you want to do a sonogram on every person you see before you prescribe this drug, realizing that it has decreased effectiveness at 14 weeks than 10 weeks, so therefore you're prescribing a Category X drug to a pregnancy that's probably not going, that has a possibility of not being aborted. So you're increasing the risk of fetal anomalies. It just doesn't add up to me. Why are you scared to do a sonogram? Wouldn't you think if you were doing an abortion procedure on a 12-weeker versus a baby that's actually 20 weeks, that it would change everything? I'm just appalled that why you all are so afraid of doing sonograms. Thank you so much, and I yield back.
I'll allow you time. I'll allow you time to answer that question, Dr. Verma.
Thank you. And I will say, as a doctor who actually does provide this care to patients and is currently practicing, we actually often do sonograms if there's any questions. So when we see a patient and we're providing medication abortion via telemedicine, we go through screening questionnaires, and if there's any concern, we absolutely do a sonogram. So that isn't really an accurate representation of how this practice of medicine works.
Thank you.
Thanks very much, Director. The CBO, about 2 months ago, released new estimates that project that an extension of the 2017 Trump tax cuts would add $4.6 trillion to the debt over 10 years. Is that correct?
Yes, that's correct.
And does CBO believe that the original 2017 Trump tax cuts paid for themselves? And does any CBO data support that extension of these tax cuts would pay for themselves?
No, there was a effect of the tax cuts on the economy and back to revenues, but by far it did not pay for itself, and the same would apply for the extension of the 2017 Act.
CBO's long-term budget projections back in 2012 were the last time that CBO showed debt declining as a share of GDP. Since then, Congress has cut taxes numerous times, including extending most of the Bush tax cuts and then piling on the 2017 Trump tax cuts. Is it a fact, Director Swagel, that projected primary spending, that is federal non-interest spending, is now lower than it was projected to be in 2012?
That's correct. And the interest payments have gone up, but as you said, the non-interest payments have gone down.
So let me just, to put this into context, let's take a look at this graphic here, which shows from 1994 to 2054 how revenues and spending have worked. Social Security has gone up, and is that consistent with an aging population?
That's right. That results from the aging population.
And healthcare spending has gone up even more. Does that also relate to an aging population?
Right. That's both the aging population and rapid growth in health costs.
So other mandatory spending had a huge surge right here. Can you explain what that was? Was that COVID?
That's COVID, and the spending because of the the Senate rules, the spending in the reconciliation bill. I'm sorry, the COVID spending and then the 2021 reconciliation spending was all mandatory.
Yes. And then here's defense discretionary spending. And then this is non-defense discretionary spending, which, as you can see, has been fairly constant over all of those years, this is the place where our Republican friends want to focus all of their attention related to debt and deficits. But I think as we can see, even if you zeroed that out, we still wouldn't get out of our problems, correct?
No, that's correct. That even if discretionary spending was entirely eliminated, that wouldn't take the deficit to zero.
Great. And then, as has been pointed out, interest costs are what are going up. That's the biggest number. And is it true that tax cuts have an effect on the interest obligations of the country?
That's right. The rising interest payments, as you noted, reflect both higher interest rates and also more debt. And the tax cuts lead to less
More
revenue, which mean more debt.
Yep. So what I've added here, this is what our actual revenue has looked like. If the Bush tax cuts had not been extended back in 2012, here's what our revenue would look like. We'd be darn close to operating in an effective way. So you can ascribe an enormous amount of our problem to the extension of the Bush tax cuts, according to, are these numbers correct? Can you vouch for the extension of the Bush tax cuts having that much of an effect on revenues?
You know, I'd have to look at it. I haven't, you know, from this distance, I can't see it. Okay. But certainly the 2012 extension of the 2001 and 2003 tax acts had an effect on revenues, as you said.
A pretty massive effect on debt and on deficits because of lost revenues, correct?
That's right. Yes.
Yep. And then one other one I wanted to show you. If you look at what's been added to the national debt, this is Trump time. 3.6 trillion was added, and that was COVID relief, so we can understand that was a little bit of an emergency. But 4.8 trillion was non-COVID added to the debt. By contrast, there's still 2.1 trillion left under Biden, but 2.2 trillion in non-COVID. So does the math add up that under Biden, the addition to the debt is less than half than under Trump?
I mean, you know, I'd have to look at the numbers, but as you said, the dollars of debt and the debt ratio went way up, especially during the pandemic, but even before that, the debt ratio went up.
Senator Grassley.
It is no secret, I think, to most Americans that our current healthcare system is broken, it is dysfunctional, it is a cruel system. It is the only system in the industrialized world that does not guarantee healthcare to all people, and yet we end up spending twice as much per capita on healthcare as the people of other nations. And the result of all of that is that our life expectancy is significantly lower than many other countries, and our healthcare outcomes are often worse. But today, we are going to be talking about one of the most outrageous and cruelest aspect of this dysfunctional healthcare system, and that is that people who suffer and are trying to deal with terrible illnesses, cancer, heart disease, whatever, not only have to struggle to try to get well, struggle to get the treatment that they need, but then in the midst of all that, they are consumed with the reality that their family may go bankrupt because of the outrageous cost of healthcare. Truth is that in America today, the leading cause of personal bankruptcy, what is personal bankruptcy? People go to Las Vegas and blow their money gambling? Are they buying extravagant homes and fancy jewelry? No. The leading cause of personal bankruptcy in this country is the outrageously high prices that large hospitals, pharmaceutical companies, and insurance companies charge the American people for the crime of getting sick. Bankruptcy takes place because you get sick and need medical treatment. Let's be clear. The medical debt crisis our nation is experiencing is a uniquely American phenomenon. Does not exist in other countries around the world. We are the only major country on earth where an emergency visit to a hospital can cause patients to lose their homes and their life savings because of the high cost of medical care. Imagine that, having a medical emergency, going to an emergency room, and then you lose your home as a result. How insane is that? I live 50 miles away from the Canadian border. And in Canada, if you spend a month in the hospital dealing with some terrible illness, you come out, the bill you get is zero. That's what you get. And that is true in most civilized, industrialized countries. In America today, over 66% of all personal bankruptcies in this country, some 530,000 per year, are related to unpaid medical bills. And after declaring bankruptcy, what happens? Your credit worthiness is destroyed. And if you are able to take out a loan, you will pay extremely high interest rates on anything you purchase as you spiral further and further into poverty and economic instability. And this is really stunning, and I really hope everybody hears this reality. This is the American healthcare system. The medical debt crisis in America has become so horrific that about 1 out of every 4 cancer patients in America either declared bankruptcy or lost their homes to eviction or foreclosure as a result of medical debt in 2022. Not enough that you're dealing with cancer. 1 out of 4 either declare bankruptcy or lose their homes. Now, how outrageous and disgraceful is that? Further, 42% of cancer patients in our country have been forced to deplete their entire life savings within 2 years of their diagnosis. And it's not just cancer patients who are struggling financially with medical debt and the high cost of health care. In 2018, 8 million Americans slipped out of the middle class and into poverty due to medical expenses. Again, punished financially for what crime? That you're diagnosed with cancer? That should not be happening. Nearly 1 out of every 4 Americans have skipped needed medical treatment because they can't afford it. Over 60% of Americans with medical debt have cut back on food, clothing, or other basic necessities. Now, some people may be thinking that medical debt is just a problem that impacts the uninsured, people without any insurance. That is not accurate. In America today, 61% of people who have health insurance have racked up medical debt over the past 5 years. In total, 100 million Americans, 41% of our adult population owe $222 billion in medical debt. Let me just, a couple of days ago, my office, through our social media, we asked people around the country and in Vermont, tell us your experience with medical debt. Let me very briefly read a few of the stories that we got. A gentleman named Eric from Oregon wrote, quote, I received a traumatic brain injury and woke up from a coma with a hospital bill of over $500,000. How are you supposed to start a new life being $500,000 in debt after being in a coma for 3.5 months? That's a hell of a way to wake up. Melissa from Montana wrote, quote, I developed heart failure from an abnormal heart rhythm in my 30s. I had no insurance. My family of 5 went bankrupt and lost their home. I'm in my 50s with a career in speech pathology, and I still can't afford health insurance, end quote. Andrea from Nevada wrote, quote, my mother got colon cancer. She did not have adequate insurance. They wanted $3,000 up front before they would start her chemotherapy treatment. It would then cost another $3,000 a week for a minimum of 10 weeks. She never got a single chemotherapy treatment. End of quote. We can only imagine what happened. So that's the bottom line. Are we a nation which says that if you come down with some terrible illness, you run the risk of destroying the financial stability of your family? Is that really where we are as a nation? I think not. And today we're going to begin to hear, and in my view, needless to say, we need to transform our entire healthcare system, move to Medicare for all, but that's not what we're discussing today. What we're at least looking at today is how short-term we can protect the many, many, many millions of people who are struggling financially because they committed the crime of getting sick. Senator Cassidy, the floor is yours.
Thank you, Chair Sanders. And
we are waiting for another senator. In the meantime, I think Senator Cassidy and I had a few questions we'd like to ask. This has been a very interesting hearing, and I think everybody, regardless of where you're coming from, understands that the root cause of the crisis of medical debt is the high cost of health care in America. And the interesting discussion is to why we are spending twice as much per capita on health care as any other nation, and our outcomes are often not as good. I would mention to folks there was a study recently at the Peterson Foundation which talked about administrative costs. Now, I would hope that most of us agree that if we spend $1 on healthcare, we want it to go to a doctor or a nurse or some medicine. We don't want to go to some bureaucrat hounding or some bill collector hounding Ms. Ward or Dr. Chino, who's worried about family members. Not a very good investment in healthcare dollars. Just for the record, in Japan, they spend about $70 a year per person on administrative costs. Sweden, $70, Italy, $74, Australia, $148, France, $306, Switzerland, expensive, $528. The United States, we spend $925 per person, not on doctors, nurses, but on bureaucracy. All right? Brief answer. Now, I'm going to give you my view. You tell me what you think about it. And this really raises an interesting question with Senator Cassidy. We may want to do another hearing, really. I think that the function of a rational, humane healthcare system is to guarantee healthcare to all people, regardless of income, as a human right. I think it's wrong if somebody says to Bill Cassidy here, Bill, sorry, you have cancer. Too bad you're going to die because you can't afford the treatment. I don't think that that's what a civilized society should have. That is what exists right now. Dr. Sayed, now go right down the line to everybody. What should be the function of a sane, humane, cost-effective healthcare system? Doctor?
I'd say it's to prevent the illnesses that can be prevented, treat the illnesses that can be treated, and to prevent the adverse consequences of getting sick in the first place.
Dr. Messak?
To look out for patients. That's the oath I take, and that should be the function of our healthcare system.
Regardless of income?
Amen. Yes, absolutely.
Ms. Ward?
To help all families and children thrive in any way that they can, the best way that they can.
Dr. Chino?
I think our health insurance system, our health care system should invest in the American people, because when you invest in the American people, it will always pay out for you.
Dr. Bai?
I believe we should make all the stakeholders able to benefit themselves. Then eventually that will benefit society as a whole. Everybody wants to be rich. Through competition, then people innovate and eventually drag down price and improve quality, benefiting all Americans.
Dr. Polito?
I think the goal should be to balance cost and the innovation that generates lots of health that we enjoy.
I just read statistics. I think there is no denying, or somebody can deny it if you want, that our system is not only the most expensive, it is the most complicated, the most bureaucratic. Everybody in America spends half their lives filling out forms, arguing with insurance companies, all of which cost an enormous amount of money. Dr. El-Sayed, what is the solution for creating a simple, cost-effective healthcare system?
We've heard a lot about providers and payers, and it's important for us to differentiate between those two. Healthcare providers are the doctors, the hospitals, the folks you see to get care. That should stay private. It encourages competition, and competition is good. But there is no innovation. There is no improvement on the insurance side. This is an industry that sits as a middleman between individuals.
What is the function of the insurance industry?
In theory, they're supposed to protect you from the financial consequences of getting sick.
In
reality, it's to make a lot of money for CEOs of large health insurance corporations.
Dr. Messak?
I agree. We have to cut out the middlemen in healthcare. There's way too much money floating around between patients and the healthcare providers that's never benefiting patients at all.
Why is it, anybody jump in, that we are spending less than half as much per capita on primary health care than virtually every other major country, where I think we all understand the function of a good healthcare system is to keep people healthy? What role do the insurance companies? Do the insurance companies make any money by keeping you healthy? Dr. Chino?
No, sir, they do not.
Dr. El-Sayed?
Yeah, I'll say as a public health official, this is a place of mass frustration because in theory we should, but we've made Medicare the insurer of last resort rather than the insurer that should cover you your whole life. And so what happens is any investment that they make in prevention early on is going to redound to Medicare's benefit. So there's really no incentive for them to invest up front in keeping you healthy, but rather we have a situation where they're being subsidized over the long term, and so that prevention is not happening.
Thank you very much. Let me begin the round of questioning by mentioning that last week the governor of Illinois signed legislation into law to cancel up to $1 billion in medical debt with an investment of just $10 million in state funding. That sounds like a pretty good deal. We're talking about 1 cent on the dollar to cancel debt. Dr. El-Sayed, is that similar to what you're doing in Michigan? Why is that an effective way to go forward to take the burden of medical debt off of the backs of vulnerable people?
Yeah, thank you for the question. So the ratio of 1 cent on the dollar is exactly what we're pursuing in Wayne County. And it demonstrates the fact that though prices have gotten higher, those nominal prices are somewhat arbitrary. And the reality is that after non-payment of a medical debt, the value of that debt falls precipitously. And so we have a situation where I would argue that it's actually exactly the inverse of what my esteemed colleague, Dr. Ippolito, shared, which is that we have a situation right now where hospitals and providers, in effect, will create a certain number and say that's the price of the care. And people can't afford it, but they bank on the fact that a lot of people, because of the kind of beggaring that they get, will try and do so anyway.
How many people do you think you can help by removing their debt for how much money in Wayne County?
We estimate about 300,000.
For how much?
For about $7 million.
That sounds like a pretty good deal.
Yeah.
Dr. Messack, in America, 1 out of every 4 cancer patients either declared bankruptcy or lost their homes to eviction or foreclosure as a result of medical debt. Is there any other country in the world where that takes place?
No, not in the rich world. Countries as rich or close to as rich as the United States do not see this level of catastrophic health expenditure, not even close. We outpace the nearest OECD country by more than 2 times. So you're right that that's not something we see.
All right. And if I am diagnosed with a terrible disease, I worry about that a whole lot. My family worries about that. What impact on my health and my well-being does the worry about financial ruin mean to me?
Thank you, Senator. As Dr. Chino said, and as I mentioned in my testimony, there are so many consequences to worrying about health, and we know that patients who are in financial distress after a diagnosis, who are facing these medical debts, do not adhere to treatment recommendations. They're more likely to die, and this has been proven time and time again from the RAND study in the 70s and to the QJE study just this year. So it's a tremendous health consequence.
Ms. Wood and Dr. Chino, you both have dealt with serious, in one case fatal, illness in the family. What role were bill collectors playing during this process when you were worried about your kids and you were worried about your husband, Dr. Chino? Ms. Wood?
I think it's just the ever constant threat of someone calling to inquire for something that we were not able to pay.
Did that happen often?
I would say multiple times a day, up to
Multiple times a day?
Yeah, I would say oftentimes we were in the NICU visiting our children, and we would get calls from debt collectors asking for payment before the boys were ever discharged from the hospital. It caused a tremendous amount of stress on our family, up to the point that we debated not answering our phone many times if we were not with the boys, because we were worried if it was the hospital or a debt collector calling. But we had to answer because, of course, it was the hospital.
So your kid's in the hospital, and you're getting multiple calls a day?
Correct.
From bill collectors?
We had 2 children, so double the calls. Yeah.
Dr. Chino, do you want to elaborate on that, or?
I just want to say how common this is and how heartbreaking it is, that I know from my personal experience, but also that our patients are experiencing on a day-to-day basis, how excruciating these calls are, how harassing and threatening the messages are. I have patients
Elaborate on that a little bit. Threatening, what does that mean? You're dealing with somebody who is very, very ill, right? That's your main concern. What does that mean, threatening?
So, saying this is going to affect your credit, your ability to do anything in the future. We're going to take your home. We're going to take your car. Where your future is over. Basically, I have found that debt collectors will play every dirty trick that they can to try to get you to give them some money. And it's just one extra layer of stress that when you're dealing with, for me, my husband was in the ICU for a month. It's intolerable.
To say the least. I mean, so what we're talking about is a wife worried about a husband in the ICU, or a mother worried about her kids struggling for their lives, having to field off calls from debt collectors. I mean, if that's not obscene, I don't know what is obscene. Senator Cassidy?
Yes. Ms. Ward, just out of curiosity, which hospital were your children treated at?
They've been treated in several. We were living in Dallas when the children were born, and
So
then we moved
the
to
NICU,
Chicago.
the NICU bill sounds like it was the most. Which hospital was the NICU in?
They were both at Baylor in Dallas and then also
Okay.
at Children's Medical Center.
Sounds good. Dr. Messick, I assume the patient you described was treated at Brigham. Brigham's a nonprofit. They get disproportionate share, and it's a 340B hospital. All three are mechanisms by which it's supposed to help those who cannot pay their bills be alleviated from the burden. Do you know if Brigham ever reached out to those patients to help decrease their cost?
I should be clear, the patient I was talking about was at Rhode Island, where I did my residency training, so not in the Brigham system.
So Rhode Island, if it's an academic center, typically those are nonprofit. So that would again have 340B and a tax exempt status. Did that hospital, and by the way, did that hospital, as far as you know, have a program? Or does Brigham, let me ask about Brigham. Yeah. Do they have a program where if somebody comes in uninsured or poorly insured or with a high deductible to help offset the cost of that bill?
Yes, Mass General Brigham does have that policy. If up to 150% of the federal poverty level gets free care, up to 300% gets discounted care. All hospitals have to have.
So in a sense, that mechanism is then working. Dr. Chino, what a motivation for you, but what a terrible story for us about your husband. Sloan Kettering, again, it's a nonprofit, 340B, and disproportionate share, big disproportionate share state. Does Sloan Kettering have a program where they pass the 340B discount to the patient?
We are not a 340B program at Memorial Sloan Kettering.
I think you are. I looked it up, and I think I saw that you are.
Okay, that is news to me. I apologize. But I will say that our charity care program is actually quite robust.
But do they pass that, because you mentioned specifically the cost of drugs, do they pass that 340B discount to the patient?
We cover up to 500% of FPL for our charity care program, which is far more than we need to.
So is that for the uninsured, or would that include the people with a less generous insurance policy?
Up to 500% of FPL, yes.
So in that sense, the programs we have would address that portion of medical debt that would be at y'all's hospitals. That's important.
It's important, but you also have to realize that in New York City, even up to 500 FPL is not necessarily a livable wage. And I know that sounds insane. And when you think about a charity care program, for example, for my husband, he was underinsured, but he was also a college professor. So we did not meet any actual charity care program. And yet we still fell into massive debt related to his care.
Presumably he would have been below 500% of FPL if he was...
he was not treated at Memorial Sloan Kettering.
Got it. In the hospital where he was treated, was that a 340B nonprofit?
I apologize, I do not know that, sir.
Okay. Do you know the name of the hospital?
He was treated at the University of Michigan initially.
Well, that would have been that would have been a 340B nonprofit. Dr. Bai, what we have here, at least in a couple cases, may be cases where a 340B nonprofit receiving disproportionate share dollars is not helping people with their medical expense. Is that a... And as it turns out, my staff just tells me that Baylor is also a 340B hospital nonprofit. So theoretically, we have hospitals which are supposed to be doing the right thing, and they're not doing the right thing. I guess it's not a market failure, but it's certainly a failure of a hospital to act in a way which would be consistent with that was intended by the policymaker. Any comment on that?
I believe that's exactly what the policymakers are trying to do. All these policies are in favor of large players, in my opinion, trying to build a coalition between the policymakers and the large players. So large players will just ignore what the patient needs and focus their effort on this influencing, capturing the regulatory process, legislative process. So they got the best benefit, like more 340B, right? More site-based payments.
So they would act for more subsidy, but yet we have clear instances of that subsidy not being passed to the patient. Two things about your testimony. You said only 14% of people have a medical debt over 10K. In my statement, I mentioned that 50% of medical debt is related to hospital expense. So really, if these policies were actually implemented as intended, it would have a very positive impact. Dr. Ippolito, real quickly, I'm almost out of time. The No Surprises Act was supposed to eliminate surprise medical billing, and that was a major cause of medical debt. Has there been an analysis of the accrual of medical debt subsequent to the passage of the No Surprises Act?
Not that I'm aware of, but in theory, it should have helped.
Yeah, certainly the testimony we received at the time was a lot of medical debt was related to, I thought you were in network, turns out you weren't. And now No Surprises addresses that. Maybe that will be a policy that actually works. Mr. Chair, I may have a second round, but I'll yield right now.
Senator Mullen.
And I'll try to be as brief as I can, but it's going to be a little longer because this is a personal story about my son. I'm very involved in traumatic brain injuries because of my son, Jim Mullen, who now wrestles at Oklahoma State at the age of 20. But at the age of 15, he had a traumatic brain injury, which led him to not even be able to walk, not be able to touch his nose, not be able to read, write. And at the time, he was a high school and freshman, nationally ranked, had wrestled all over the world for the junior world team. We knew something was wrong with Jim. And we had taken him every place. He'd been wrestling since he was a little kid and was absolutely amazing at the sport. But something just wasn't right. And we didn't know what it was. We'd sent him to several concussion specialists. We ended up getting referred to the Cleveland Clinic. And this is no backhand to the Cleveland Clinic, but the truth is if you speak to 12 neurologists, you'll get 12 different opinions. And we went to the Cleveland Clinic, spent 2 weeks at the Cleveland Clinic. And at the end of it, their conclusion was that it was in his head. Not in his head, like in his head, but mentally, they said, this is what the neurologist told us, that this is his way of telling us he doesn't want to wrestle anymore. Well, we never pushed Jim at wrestling. Jim loved wrestling from the day he first stepped on the mat at 6 years old, and he never stopped it. He was the kid that was always looking for practice, wanting to go to practice, walked out of practice, and all the other kids would be crying, and you'd ask Jim how he was doing, and he'd say, oh, Dad, I loved it. And so we knew it wasn't right, but we said, well, okay, if it's nothing with neurology saying nothing's wrong with him, then we're going to go ahead and let him wrestle. Well, literally 3 months later, he's wrestling at Newton, Kansas. He gets hit in the head. I'm coaching, and he walks over to me, and he says, Dad, I don't feel good. And he looked at me and collapsed. Coded, had severe oxygen depletion. We, of course, rushed him to the Wesley Medical Center at Wichita, Kansas, and he's in the pediatric ICU there, and he woke up 26 hours later. He didn't know who he was, didn't know his name, didn't know who we were, knew we were somebody, but didn't know who he belonged to, didn't know what year it was. The only question he got right, and this is no political joke here, was who the president was. He said Trump. And, of course, President Trump found that hilarious. And then he started testing him. And they had him just do simple touches. And the issue is that he couldn't touch his nose. And then they got him up to walk, and here's an elite athlete, and he was shuffling his feet and had to put a safety belt on him. And the neurologists at the Wesley Medical Center told us, we'll go home and it'll eventually wear off. That's what we were told by the lead neurologist there. Fortunately, we got hold of the Center for Neural Skills in Bakersfield, California, and the founder of the place, called Mark Ashley, gave us a call while we were in the hospital, and he started asking for his medical records, and we started giving him all the medical records, and he said, has this happened, how long has this been going on? And he started hitting all the points, and the first time as a parent, it was like, we got somebody that actually got answers here. Well, what ended up happening was an 18-month journey for us being at the Center for Neural Skills and him learning every skill again. It's so hard to see your son that can't even put together a kindergarten puzzle. And before this happened, he was taking advanced classes in school, and not being able to hold a plank or be able to bring his feet up. And we couldn't, literally doctor after doctor couldn't give us answers. They told us it was going to be 3 years of intense rehabilitation. And Jim's attitude was, he said, Dad, I learned it once, I can learn it again. So he had a good attitude by it, right? I still have problems with it. I don't think I've ever quit crying over it. One of the hardest things that I've dealt with as a parent to see your kid go through this. They said he could never wrestle again, said he would never be able to play sports again. Of course, he's defeated odds. Like I said, he's wrestling at the University or the Oklahoma State University right now. But my point of all this, the reason why this is so personal, and Chairman, I appreciate you indulging me in so much extra time, is because there's so much more we need to know. And with this, with the reauthorization of the brain injury program, it gives families hope. It gives people the ability to have some place to turn. It gives researchers, those that are trying to dive into this, some more answers, because it's not the doctor's fault. It's not the neurology fault. It's not the Wesley Medical Center. It's not the Cleveland Clinic. I don't blame them. They did the best they could. It's just they did the best they could, and there's so much more that can be done. There's so much more studies that need to happen. There's so many more answers that need to be that need to be explained. Like, I didn't know a frontal lobe injury causes you to have for adolescents, that it stunts your growth. We had no idea that until we were 3 months into it, and 3 months into it, his growth plates is closed. So Jim's going to be 5'3" the rest of his life, which is fine. But it's little things like that. If you had the information ahead of time, you can make better informed decisions, which we didn't have. So I appreciate this committee working in this manner. Senator Lujan, I hate that you started it with an emotional, because you got me emotional before I even started, and I don't cry, I promise you. Actually, I do. But I do appreciate this committee working in a bipartisan manner, because this is something that's important to all of us. We've heard the stories around here. So thank you. Senator, Chairman, we don't always get along, but in this, I do appreciate your attention to it.
Thank you, and thank you. I mean, this is what real legislation is about. It comes from personal experience, and we thank you very much, Senator Mullen, for sharing your own experience, and we wish your son the very best.
Senator Capito.
Thank you, Madam Chair, and thank you, Vice Chair Collins. I know you all both have a great passion for the bill that we are under consideration. As we near the end of our subcommittee markups, I'd like to thank the leaders of this committee and all of my fellow committee members. Chair Murray and Vice Chair Collins have once again delivered on their promised commitment to regular order, and I hope that continues on the floor, and we've heard that echoed by several other members today. The Labor HHS Appropriations Bill is one of the most difficult appropriations bills to negotiate and is the largest non-defense discretionary bill. This is the second year that Senator Baldwin and I have been at the helm of the Labor HHS subcommittee, and I'm pleased to say that once again we present a bipartisan bill to the full committee. I want to thank her for her hands-on, dedicated passion that she brings to the table as the chair. The bill continues our bipartisan record from last year and maintains all long-standing riders and does not include any new controversial riders. The bill includes a number of bipartisan member priorities, such as, and the chair enumerated many of these, and I'm going to go through a few that are important to me, such as greater investments in America's biomedical research, child care, mental health, workforce, strengthening biodefense, and continuing efforts to combat the opioid epidemic. Our bill provides an increase of $2 billion for the National Institutes of Health to still prioritize basic research in the United States. The bill does not provide funding for the Wuhan Institute of Virology or Echo Health. The NIH investment restores cures funding for the Cancer Moonshot, Brain Initiative, and All of Us research program. We have also provided targeted increases for research in such areas as Alzheimer's, mental health, women's health, maternal health, and cancer, including a $20 million increase for the Childhood Cancer STAR Act. As we provide a $25 million increase, we also provide a $25 million increase to the NIH IDEA program that provides funding to 23 of our states that historically had lower levels of NIH funding, including our state of West Virginia. This program has been so important for research at West Virginia institutions like WVU and Marshall universities. Today's bill also builds on our efforts to fight the continued problem of substance abuse, particularly fentanyl, which remains a serious problem in the country and particularly in our state of West Virginia. The bill provides $4.6 billion for addiction treatment, prevention, research, and recovery programs. It continues a multi-pronged approach including efforts to slow the addiction epidemic. $1.6 billion for the state opioid research response grants to address the opioid epidemic ways that suit individual state needs. $2 billion for the substance use prevention and treatment block grant, and $660 million for the NIH Helping to End Addiction Long-Term, or NIH HEAL initiative. This bill also provides significant resources in our health workforce. I am sure everyone at this table and everybody in this room, anytime you visit a health facility, workforce challenges are rampant across the country in the health field. It helps to increase the number of counselors, social workers, peer support specialists, and clinical professionals to respond to the addiction crisis, which will help our providers. Health workforce training investments are also included to educate and retain nurses and to grow the number of geriatric providers to care for our aging population. That would be Senator Kennedy. Couldn't resist. The Labor HH bill again prioritizes our children, starting with early childhood education all the way to college, to make sure our students are prepared for the jobs today, but also in the future. Specifically, a $1.6 billion increase to the Child Care and Development Block Grant that many of us had asked for, a $700 million increase to Head Start to support our early childhood education, $280 million increase for Title I to support students in low-income schools, $300 million increase for IDEA grants to states, which provides special education services for students with disabilities, and the $100 increase to the Maximum Pell Award, for a total of the Maximum Pell Award will go to $7,495 for the 25-26 school year. I've just described several bipartisan programs we have included to improve the lives of Americans, and I encourage my colleagues to support this Labor HHS bill. I am going to thank our staff again. Senator Baldwin did a good job, but I would like to start with her staff: Mike Gentile, Mark Leish, Megan Mott, Catherine Tumujan, Aaron Dugan, Amanda Beaumont, Claire Montero, and Janie Dulaney. On my Labor HH staff, we were texting at 4 o'clock in the morning this morning: Lindsay Seidman, Ashley Palmer, and Emily Slack. In my personal office, my chief, J.T. Jazerski, James Mann, Thompson Moore, Dana Richter, and Mimi Vance, and the full committee staff that helps all of our subcommittees: Clint Trocchio and Ben Hammond and the wonderful GPO team. So thank you again to the chair and to the vice chair.